is iso-functioning with the rest of the thyroid gland, but the chance of having malignancy is as high as a cold nodule. It is 30% in both the cases. And the other one is hot nodule, which is an FTN, less than 1% chance of having malignancy. This is just a scan for a multinodular Graves, so I'll not elaborate on it. This is a euthyroid multinodular goiter. As you can see, euthyroid because the salivary glands are looking fine. And the largest cold nodule is something that we suggest to undergo an FNSE. This is ectopic thyroid. You all know the lingual thyroid, and as you can see here, this is the lingual thyroid. And this is two ectopics. I mean, this is basically two ectopics. Most of the time, the indication is to see whether the native gland is there before we do a surgery. The same indication goes for thyroglossal cyst, etc. Not elaborating. Is there any role of FDG PET CT in the evaluation of thyroid nodule? The answer is no. Clear cut no. There is no indication unless the FNSE says anaplastic or aggressive behavior wherein you are staging the patient like any other malignancies. But for differentiated, say, thyroid, or you're evaluating a thyroid nodule per se, no role of FDG. People do TG, etc. in the preoperative evaluation. All those you know better than me. So it's a 45-year-old male. It's a follow-up case of lymphoma, presented with left axillary swelling and bilateral pedal edema. So this is like the clinician is thinking of a recurrence of the lymphoma. So there was a PET CT done. This is a whole body FDG PET CT. FDG means fluorodeoxyglucose, localizes in hypermetabolic cells. So as you can see, the axillary node is taking up the glucose, confirming the relapse. But I did not show you this scan because of this. I showed you because of some incidental finding. That look at the thyroid, both the lobes are taking up glucose. Now this is a very common findings in our day-to-day clinical practice. Most of the time these are non-specific. In our literature we call this autoimmune thyroid disease of any kind. But there are some similar situations, some other clinical situations wherein the thyroid can take up this kind of glucose. It can take up so much so diffuse uptake in a Graves' disease because it is a hypermetabolic gland. In a very different clinical context, a man with a PUO, this is published in AJR, but we had a patient, doctor's father, PUO patient, FDG PET CT is now indicated. So we did a scan and we found this kind of an uptake in the thyroid with some nodes. So I thought in the PUO I was thinking of thyroiditis, but TSH value was not there. So I went and palpated the patient. He's an elderly individual. So it was tender. Then the second day we did a standard thyroid scan to confirm thyroiditis. He was admitted in our hospital in MRI with PUO. So he was diagnosed. The physician is a very senior one and he was so sorry. He said that I should have thought about this. I shouldn't have asked for a thyroid scan. But if I remember correctly, somehow Harrison's textbook does not mention TSH as one of the tests in the evaluation of PUO. The algorithm, if you look at, it does not include TSH whatsoever. There is another case. So my idea was to show you diffuse FDG uptake in thyroid. Either can be non-specific autoimmune or can be thyroiditis or Graves'. And this is a 30-year-old female with intractable cough. For 2 years, she was having diagnosis of different kinds, DCM, then TB, then sarcoidosis. She had a final biopsy diagnosis from the bronchoscopic lavage as CA lung with stage 4 disease. This is what it was written in the discharge summary of the patient. It is a patient, I scanned her in 2010. And this is my favorite scan, so I show in every conference. So this was the PET CT looking like too much of FDG uptake in both lungs. This is the CT pictures. You can see miliary nodules, so I do not blame anybody labeling it as a TB or a sarcoidosis. So I was just wondering that how come the diagnosis of CA lung stage 4 disease, she was already given a chemotherapy schedule. But what I was thinking is, where is the lung mass? They have not biopsied from the lung mass. So I could see one small nodule in the lung, but then it was also too small, for us. And 2-year history, young female. So incidentally, we got to see this thyroid nodule which was taking up. So please remember, any incidentaloma which takes up FDG, the incidence of having an occult malignancy is around 40%, 39% to 41%. So this was reported as a possible thyroid malignancy with lung metastasis. Subsequently, FNSE was done, and this came to be a CA thyroid with lung mets, and she underwent total thyroidectomy with iodine therapy. She is alive, And so you can think, this is beauty of a PET scan because you see the whole body, you can do all permutations and combinations to do the pattern recognitions. So this is the latest kid in the block. I just had a glance because of this conference. Every year we have been reading from since 96, and then so many updates. Sometimes I feel, what is the change actually? I mean, that you have to make some certain changes, you make changes. They have removed lower ablation and everything in this one. So iodine scans for DTC, as I told you, there is no role in pre-surgical workup. The only reason is whole body iodine scan, only indication in a proven DTC patient post-total thyroidectomy when you are planning for surveillance or therapy. I mean, iodine therapy, pre-therapy, you want to see the residual or the metastatic disease so that you can do the dynamic risk stratification. I mean, all of you are aware of it. What are the preparations? Iodine restriction is the mandatory thing. No CACT or iodine-containing medicines, like the dressing has to be in not on iodine-containing betadine and etc. It has to be on the spirit filled, and the food, of course. And this is generally the iodine scans post-surgery. One is normal, the other one is showing neck residues, and the last one is showing metastatic disease in both lungs. The regime is, when we do a follow-up, say 6 months, 1 year, there are standard regime is TSH withdrawal, I mean LT4 withdrawal, and when the TSH rises to more than 30, we give iodine. This is called, this is the standard. And the other one is RH-TSH. So 1 or 2 doses of RH-TSH. Very surprisingly, the ATA 2025 has mentioned, this is, RH-TSH is the most preferred way. I mean, I've been very happy with LT4 withdrawal. When I tell my patients, you spend 70,000 rupees or you tolerate your hypothyroidism for 3 weeks, they choose the second one. But of course, ATA has now paved the way to use RH-TSH as a strong recommendation, etc. So people will, so increase of RH-TSH will, of course. Now there is something called TENIS, you know, that is in the follow-up. TG is elevated and the iodine scan is negative. That is the only indication of doing FDG PET CT. So FDG PET CT comes in picture of thyroid disease, thyroid cancer only in this case of TENIS because there is a flip-flop. The differentiated cells have become undifferentiated. So you do an iodine scan, you get this kind of an image. You do an FDG, you see more lesions because they are undifferentiated cells. And you decide your therapy accordingly. So this completes most of the thyroid scanning. Iodine therapy, I'll not elaborate much, either for benign or cancer patients. Benign patients, that as per our country regulation, we can give maximum 30 millicurie of radioiodine in a OPD setting. So the departments who do not have a functioning high dose ward, they cannot admit patients and give higher dose. CA thyroid is treated as per the ATA risk category. In case of radioiodine ablation in benign thyroid disease, this is generally we follow, we do a scan just to rule out a thyroiditis, generally fixed dose of 10-15 millicurie. Our goal is to make it thyroid disease, I mean cure hyperthyroidism. The goal of the treatment is to cure hyperthyroidism. We don't mind the patient to become hypothyroid. So, and in pregnancy, all these things that you know better. This is the recommendation, recent recommendation of radioactive iodine therapy in DTC in different risk category. You can do it for, you can use it as an ablation. You can also do it for adjuvant therapy, and you can use it for a targeted, I mean, metastatic disease treatment. This is the standard dose. If the patient is more than 70 years of age and the renal functions are poor, then you have to accordingly reduce the isotopic dose. This is just a slide. I think Puneet will show you more because his talk is on theranostics. When you are dealing with a neuroendocrine tumor like group medullary CA thyroid, the scan of choice changes. In suspected relapse, you do a DOTA PET, and there are DOTA NOC, DOTA TOC, and DOTA TET, so accordingly you use. So this summarizes the nuclear medicine studies in thyroid diseases per se. So I have told you about technetium scans, I've told you about iodine scans, and when to use, when not to use. Also showed you about therapies. So now coming to parathyroid imaging. The main indication is to identify, because the solitary adenoma is the most common clinical entity. So the most common indication is to plan for a minimally invasive thyroid surgery. There is one thing that I will not be touching upon is the radio-guided parathyroid surgery. So this is because I thought this will be too much, so I have not included this. Now you need a proper site of localization of the scan. The first investigation of choice is definitely USG. USG has its own limitations in evaluating the parathyroid, even the standard CT. So the CT that is used is a 4D CT. And I think all of you know, the problem of 4D CT is nobody is sure about the phases. You know, there are so many overlapping literatures with so many protocols. Our senior colleague, Dr. From AIMS, he has, he has a lot of experience. In fact, I had a word with him. 4D CT is, but 4D CT is one investigation that is there in the practice. And very commonly, we get a request for a Sestamibi scan. Please remember, Sestamibi is basically an radiopharmaceuticals which we use for cardiac imaging, myocardial perfusion scan. The similar agent is a tetrophosphine. So both of them have been in use in imaging parathyroids, but Sestamibi is preferable. The pharmacokinetics or distribution of tetrophosphine is not as good as Sestamibi. Of course, there are multiple papers with tetrophosphine. Some people, I have also done tetrophosphine, but I think Sestamibi is better. And there are studies, I'm not going to show you all those studies with all sensitivities and specificities. These are the USG versus Sestamibi comparative chart. So most of the cases, most of the scenarios, Sestamibi perform better because there are certain inherent limitations of USG, particularly short neck, multinodular goiter, ectopic glands. So this is how the different ectopic glands can be in a context of parathyroid adenoma. The red ones are superior glands, positions of ectopic glands, and blue ones are inferior glands. Inferior glands are generally located more anteriorly. So this is a pictorial demonstration of possible ectopicity of parathyroid glands. Now why Sestamibi? Because Sestamibi localizes in mitochondria. Any highly dividing cells have more mitochondria. So that is why Sestamibi is used. And there are different types of Sestamibi scan. One is a dual isotope subtraction image. This must be there in the textbooks, and I'm sure our seniors have done a lot. Not that I have done much. We had done during our training period, but then not practiced. These days, the practice has moved into a delayed Sestamibi scan. That means a 2 or 3 hour delay image after you give the injection. What is a subtraction image? You do a standard technetium thyroid scan to map the thyroid. Then you do a Sestamibi scan. Then in the computer, you subtract both the images. So the thyroid gets removed. The only thing that is there is the Sestamibi focal uptake. So you localizes the adenoma on the basis of this kind of a computer subtracted images. This is called as technetium Sestamibi subtraction dual isotope scans. So these are two scenarios. One is here and the other one is here. But what we use is a delayed scan. Delayed scan means you inject Sestamibi. There are different protocols. Some people do a 10-minute, 30-minute, and 2 hours. Some people do only 2 images, maybe 30 minutes and 2 hours, depending upon center to center. I do it as 10 minutes, 30 minutes, and 2 hours. And as you can see, the retention of tracer at the delayed image, in the delayed image, is what is diagnostic. So as you can see here, the entire thyroid is taken up with a little more focality in the right inferior side, but this is retaining tracer. So this is a right inferior adenoma. These days, what we are doing is SPECT CT. So similar like PET CT, we can do a 3-dimensional image of the parathyroid and subsequent CT scan. Not every center has it as of now. That is why it is not the standard care of recommendation. So a lot of centers, what they do is they do a SPECT and they take the patient to PET CT machine and do a CT and then fuse. So what the advantage is, if you are seeing an uptake here, you do a CT, you see this kind of a small ectopic parathyroid even in the mediastinum. You get both radiological and the nuclear medicine correlation, because the biggest criticism of nuclear medicine is unclear, because you don't get the anatomy. So if you have both the fusion, then it is, of course, so easy for the clinicians. There are limitations of Sestamibi scan, of course. It is false negative in many cases, precisely for these reasons, and also for some molecular levels, P-glycoprotein expression, MDR, gene expression and etc. So what are the other scans that we can think of in the nuclear medicine context? There are two PET CT which has come up. One is fluorocholin and one is a gallium level. Gallium is mostly, you know, about the DOTA NOC and PSMA and so many, but gallium-68 is like our new technetium. So any department who has a gallium-68 can do so many things. Think, as an endocrinologist, think about Exendin, think about, new molecule is, here is trivexin, that is for parathyroid and some pancreatic malignancies. So I'll show you 2-3 images of that and wind up my talk. So is there any role of PET CT? Yes, fluorocholin and gallium level trivexin. Why fluorocholin? Because any PET image, for example, if we have to offer you scans for a same clinical dilemma, and I have an option of offering you PET versus SPECT. Generally, we will offer you PET because it is much better imaging, much better resolution, much better clinical informations. So historically, whichever isotopes, similar isotopes are now available on PET, we are moving from gamma to PET. So now that we have PET as a possibility, we have these isotopes available. Fluorocholin shows better imaging characteristics. And this is how a fluorocholin PET in the context of suspected parathyroid adenoma looks like. As you can see, the uptakes are very discrete. Since PET is always PET CT, if you want, you can do a contrast enhanced study. You can even add on 4D if you have that expertise. So you have these two parathyroid adenomas in a same patient. This is a fluorocholin study, fluorocholin PET or FCH PET. It is just like FDG. The only thing is you do not need a fasting patient in this case because you are not using glucose as a substrate. And if you see in this case, this is interesting. Ultrasound showed a nodule in the thyroid, but it was a suspected case of parathyroid adenoma. The CT showed this nodule here. And this is a Sestamibi SPECT CT fusion. So if you see, this is the fluorocholin PET. You see two uptakes. There is another uptake here. Interestingly, this is the small paratracheal lesion which picked up on the fluorocholin scan, but which was negative on Sestamibi scan. So it clearly outperforms a Sestamibi scan. Problem is, fluorocholin is not produced in all cities. For example, Kolkata does not have fluorocholin. Recently, I really tried to get it from Delhi. The isotope was supposed to reach at 5 o'clock. Then the flight got scheduled. It was supposed to come at 7 o'clock. Then somebody called that the isotope is lying at Delhi or put at 3 o'clock, but the flight is going to arrive at 11 o'clock in the night. And the patient is sitting in my department. You can imagine my situation. So whatever, so we cancelled and we stopped thereafter. And the same happened with my FDOPA. So this is the last scan, gallium labeled trivexin. This is it targets the integrin receptors. This is the new kid on the block, and many people are doing it. But of course, any new thing that comes up, I take it a little with a pinch of salt because you'll get to see the sensitivity specificity going into 100%. Because, but then imaging, whatever is reported is promising. This is a MEN patient. So as you can see, here, this is a standard Sestamibi scan. You can see a faint tracer uptake here. So possibly an inferior adenoma. But then trihexyvin PET, see, there is no background. Actually, when we give the isotopes, most of the scans, the isotope does not only go to the target organ, it also goes to other organs. So that creates a background. And if the background activity is much lesser, then you get to see the pop-up radioactivity much, more. So in this case, if you see this three localization of trivexin isotope, so these three are the lesions, and you have a corresponding CT. This is possible in most of the nuclear medicine department these days because gallium is available with us. If you have, we have around 20-25 PET CT departments in this city now. I think 10 of them have gallium, so it is easy for us, and we can do it any day. We do not need to depend on anybody. And this is my last scan, same suspected parathyroid adenoma. If you see the Sestamibi, it did not show anything. This is the early image, the thyroid, the delayed image. But you see, there is an uptake of trihexane there. So what is the take home? You want to, so the take home is, of course, the USG remains the first line imaging. Then the Sestamibi dual time imaging with or without a SPECT CT. And if you patient can afford, then fluorocholine or trihexane, whichever is available. In Delhi, Bangalore and Bombay, fluorocholine is available. You can use it. We do not have it here, so we will resort to trihexane. So thank you very much. I think I'm on time. Thanks. Thanks.
So thank you very much, Dr. Dipanjan, for wonderful discussion. And we'll take the questions during our panel discussion period. Now I would like to call upon Dr. Umuranjan Satra. He's the consultant at CNCI Rajarhat. He's very close to my heart and is very much knowledgeable. We will discuss now regarding the nuclear scans in adrenal pathologies. There are many recent advancements happened in these days. So I think Dr. Satra will definitely discuss the particular points regarding adrenal imaging.
Okay, good morning everyone, and thank you all for coming for this session. And I want to sincerely thank the organizers and especially my friend and brother, Dr. Ojitesh, for inviting me to such an occasion. Okay, let us start. So, actually, I'm going to say on how nuclear medicine will help in the evaluation of adrenal lesions. Okay, as you know, most of the adrenal lesions are detected incidentally. 85% of them are incidental, and 15% only functional. In case of functional, you know that there is clinical symptoms, and you do biochemical tests like cortisol, aldosterone, and metanephrine, all the things you do. And then you do a CT scan or MRI, and you find an adrenal lesion. And incidentally, you may detect for any other, you are doing some test for any other causes, and you are detecting it in CT. So first you are detected it, and then you are going for biochemical evaluation, and if needed, if we want to do some functional imaging. So in case of functional lesions, we always do appropriate functional imaging. For incidental, if needed, we can go for it. Okay. So for CT is usually the first imaging. You can benign, you can differentiate the benign lesions by typical features like homogeneity. Okay. So the this is one of the how MCCT you can see if typical fat attenuation is there less than -20 HU, and you go for it myelopoma. If between 10 to -20 it may be so lipid rich adenoma, or so in that case you can go for if there is more than 10 HU, so then it may be lipid adenoma, it may be it is malignant. So for you can go directly to histology, or you can see that CT washout, CT washout pattern. Hello. Okay. So, so if there is confusion, you go for a washout imaging. If more than washout, you go for you can tell that this is diffuse adenoma, and if or you can go for a follow-up scan after 4 months, 6 months, like you can go for a follow-up scan. If it is stable, you go for lipid poor adenoma. It is progressing on follow-up, then it is malignant. Same in MRI also, there is certain criteria. You can see the chemical shift, you can see the PET suppression or signal drop in phages, and you can see the contrast enhancement in malignant cases. So these are benign features if there is chemical shift and there is fat suppression. Okay. So now if we come to the functional imaging, let us see what are there in our stores. So we have SPECT imaging and we have PET CT imaging. As you know, SPECT is always inferior to PET CT because of the physics and the technology and the energy peak. PET CT always has higher spatial resolution, and it is better, always better than the SPECT. So we have these radio tracer in SPECT. That is Iodine 131 MIBG. It is technetium Heineck-Tock, indium octreotide, and N59 scintigraphy. This is also 100 iodine level. This is not level in our country. This is not available. This is we can do this one, but this is usually leveled with 120 iodine 123, and that is also not available in our country. But and there is supply issue. So 99 technetium Heineck-Tock and MIBG, these can we do in our setup. Okay, and this is there is PET CT. PET CT I told already. This is very much better than SPECT. Already Dipanjan also told. This has both functional and anatomical integrity, and this is much more sensitivity specificity, and this is also available. Okay, so these are the different PET CT radio tracer available. For us, FDG, we know all FDG used in all type of malignancy, and it can be used also in adrenal evaluation. So there is somatostatin receptor imaging, SSTR imaging. So that those tumors which express somatostatin receptor like NETs, we can do this somatostatin receptor imaging. That is gallium, DOTA, TOC, TET, these are all one type of, and F18 level also NOTA OC is there. But this is much more in use because gallium generator is available in most of the centers, and it is like technetium generators today. So we can use this for leveling of different type of radio tracer. Then DOPA decarboxylase pathway is there. So F18 fluorodopa, FDOPA. Then chemokine receptor 4, gallium pentoxide 4, and there is adrenocortical enzymes targeting radio tracer, that is 11C, metomidate. Okay. So now this I just put this slide to understand the pharmacokinetics of the different tracer. If we can understand that pharmacokinetics and the tracer, we can figure out which tracer is most suitable for which imaging. Okay. So basically there are some adrenal cortex tracers and there are some adrenal medullary tracers. Okay. Adrenal cortex tracers are this is NP59. One is UA. This is basically cholesterol analog. So you know that cholesterol is needed for the steroid hormone production. So it should go to the adrenal cortex. So that's why we are targeting this NP59 when we get same pathway like cholesterol goes to the adrenal cortex. This also goes to the adrenal cortex and trapped there. So when we want to image the adrenal cortex, we can do this NP59. Then 11C metomidate. This is actually 11 beta hydroxylase enzyme inhibitor. So that is required in the final stage of production of aldosterone and cortisol. So there is two type of actually CYP-B1 and CYP-B2. B2 is more specific for aldosterone, but this is CYP-B1 inhibitor. So it goes for both. So in that case, whenever you want to do some aldosteronoma, you want to see the aldosteronoma, because it goes to both this zona glomerulosa fasciculata. So we have to do cortisol suppression before imaging. If we do cortisol suppression, then can only we can visualize more in this outer cortex. So whenever in hyperaldosteronism patient, so if we want to do this test, we have to do a cortisol suppression by dexamethasone before night. Okay. Then this is also same. This is only by 11C. This is only iodine leveled. This is same. Next is for adrenal medulla. We know that adrenal medulla is innervated by sympathetic nervous system, sympathetic parasympathetic nervous system, and epinephrine, norepinephrine produced. So we can use the norepinephrine analog, that is MIBG. We can which transported to medulla through vesicular monoamine transporter and stored there, and then you can use FDOPA or FDA. This is FDOPA for dopamine L-amine transporter. It goes to the adrenal medulla through L-amine transporter, and due to DOPA decarboxylase activity, it changed to the dopamine. So and trapped there. So and FDA also same mechanism, and this is also in epinephrine analog HED 11C HED. So we can also do SSTR imaging for medullary pheochromocytoma, that is gallium, DOTA, those are things. So because these tumors, neuroendocrine tumors, are always express high SSTR, somatostatin receptor. So these SSTR analogs, DOTA, DOTA TET, we can use for this. So and here is this one is chemokine receptor analog. So this is chemokine receptor 4 analog Pentix 4. So this is also we can easily available because gallium generator is there, and we can level it with gallium Pentix 4. So it is specific for aldosteronoma. So when we want to separate in primary aldosteronism, it can be due to aldosteronoma or due to diffuse hyperplasia of the adrenal cortex. So if we want to differentiate between these two, we can use this one because this aldosterone only expressed high chemokine receptors. Okay. So in differentiate between these two also. So basic pharmacokinetics, we can know what can be useful in which situation. Okay. So this is one you have detected an adrenal mass. So in step 1, you can do a CT or MRI clinical biochemical evaluation. Step 2, nuclear imaging and a specific scenario. If it is a non-functioning adrenal mass with typical appearance on morphological imaging, no further imaging is needed. If functioning adrenal mass, it may be Cushing syndrome, it may be primary hyperaldosteronism, it may be pheochromocytoma. So in Cushing syndrome, so if there is borderline hormonal results or normal adrenal or bilateral micronodular abnormality or bilateral micronodular hyperplasia, in this case there is dilemma of so, or it may be large tumor or atypical or mixed steroid secretion. In these three cases, if we can do adrenal cortex tracer, we can use adrenal cortex tracer like NP59 or mitomidate if available, because these both are not available as of now in our country. So, okay. We can request pay cyclotron people for this for 11C level mitomidate we can if you available. In case of large tumor or typical or mixed steroid secretion, so we can use FDG. Okay. So whenever we are thinking of there is malignant nature or oncocytoma, so we can use this FDG. In primary hyperaldosteronism, we all know there is AVS is the standard adrenal venous sampling. If there is failure of AVS or there is unilateral bilateral aldosterone hypersecretion, suspicion of there, then we use the adrenal cortex tracer or CCX4 analog. So in adrenal cortex tracer, that I already told that if we use this mitomidate, it goes to both if there is hyperplasia or adenoma, both will take up but this is for aldosteronoma, this can be very useful. It can distinguish. Okay. In pheochromocytoma, unreliable hormone, if there is unreliable or large tumor metastasis, if there is large tumor, we want to see the metastasis, or if there is a suspicion of inherited disease, then we want to see the multifocality. In all this scenario, so we have to do an adrenomedullary tracer like MIBG or SSTR analog tracer like gallium DOTA. Okay. If there is non-functioning indeterminate adrenal masses in non-oncologic patients, so we want to see the unknown primary or we want to see the staging, then we should do FDG. If non-functioning intermittent adrenal mass in oncologic patient, then we want to see the metastasis and we want to see testing. So in all those cases, there is FDG is needed. Okay. So FDG PET CT, as you know, this is a glucose metabolism. Its basis pharmacology through glucose metabolism, and it is helpful to distinguish between benign malignant adrenal nodule. And if there is a already known adrenal malignancy, known non-adrenal malignancy, then also it is very it is helpful. It is already known. And if there is adrenocortical carcinoma, we want to see the staging, restaging, metastasis, and we want to see the response. All stages FDG is valuable. And if there is an adrenal infection, also we can use the FDG PET CT. Okay. So you see that this is there are different types of benign tumors we have seen in FDG PET CT. So there is lipoattenuation and very minimal FDG uptake. So this we can characterize myelipoma. There is nothing, there is cystic lesions and there is no only fluid, there is no uptake. This is cyst and there is very mild FDG uptake. So we can outline it as lipid poor adenoma. Okay. So if there is an confusion about adrenal adenoma or metastasis, we can do an FDG whole body PET CT, and if you find any unknown primary like lung lesion, you see here is a lung lesion, so it is a lung primary with an adrenal metastasis. Okay. So there is bilateral adrenal mass, and we want to know that if it is a metastasis or anything else, then we should do an FDG PET CT. Then we can find that there is some primary. We will find it. Okay. Then SSTR PET CT. So we know that all entities, like all entities, pheochromocytoma, paraganglioma, all shows SSTR overall expression. So in these cases, SSTR PET CT had high sensitivity and specificity, and it is much superior to MIBG, because MIBG that is an SPECT imaging, and this is an PET imaging. So there is clear cut resolution difference is there, and it is that's why it has much better sensitivity and specificity. So SSTR PET CT can be used to characterize the tumor if it is NET or not. If there is any synchronous tumor, we can see. If it is malignant, we can use it for staging, and after treatment we can use it for recurrence, to see the recurrence or response evaluation. Okay. So you can see that this is, you clearly see that this is the two picture of same patients. So this is a biochemical pheochromocytoma, MIBG and SSTR. This is an SSTR PET CT, gallium dotanol PET CT. This is MIBG. We cannot make out anything here. And you can see that the adrenal nodule is there, and there is very mild uptake. So this is one of the problems. Pheochromocytoma always not SSTR, always not very positive here. You can see in next picture, you see this is very high uptake here in this pheochromocytoma patient, but there is not very much uptake in this, though we can figure out that this is a tumor, but this can happen in SSTR PET CT because it is because of differentiation. When it is become poorly differentiated, all entities when become poorly differentiated, there is less SSTR expression, and it will more FDG emit. And whenever it is well differentiated, there is more SSTR expression, and it will be more dotanol positive, SSTR positive. Okay. So in this case, you can figure out that how SSTR PET CT is much better than this MIBG SPECT. Okay. So here is another example. This is a malignant pheochromocytoma. So we can see that in SSTR PET CT we can see multiple metastases. You can see that these liver mets are clearly missing, not identifiable in this, because of though there is lesions, but it is very difficult to, it can be missed easily in MIBG SPECT CT. Okay, and there are so many things. It is so clearly seen, the main tumor and all the mets. Okay. So if this is another example, if there is biochemical physicosomatoma, so we are doing SSTR PET CT, so it is multifocal, multifocality we can diagnose. There is submandibular glands, mediastinal nodes, cardiophrenic nodes, bilateral adrenals. So we can, this is how we can make out the different lesions easily in this SSTR PET CT. Okay. Now, this is a large adrenal mass and borderline raised metanephrin. So we are confused that can it be pheochromocytoma or can it be ACC. So in this case, we have to do an SSTR PET CT. Simultaneously, we have to do an FDG PET CT. You can see the SSTR PET CT, there is no uptake in the lesion. In FDG PET CT, it is uptake in the lesions. So it is more in favor of adrenocortical carcinoma, okay, and this is not pheochromocytoma, okay. So in the same contrast, this patient has, you can see that SSTR PET CT is showing uptake. It is a necrotic node adrenal mass in bilaterally. SSTR PET CT is showing uptake in the solid part, and FDG PET CT is not taking the uptake here. So it is more in favor to pheochromocytoma than ACC. Okay. So there is FDOPA PET CT. FDOPA PET CT also very better radio tracer. FDOPA, it goes to the, it is also adrenal medullary imaging. It goes to the medulla through L-amine transporter system, and DOPA decarboxylase activity, high DOPA decarboxylase expression is occur in pheochromocytoma paraganglioma, so it is tapped there, and it has seen that it is it's superior to SSTR PET for pheochromocytoma, most of the pheochromocytoma patients, because I have seen that there is variable uptake in pheochromocytoma in SSTR PET CT, but that's why this DOPA PET is much superior to SSTR PET in pheochromocytoma. But it has equivalent result for paraganglioma and other NET. But problem is it is very limited availability because it is tagged with F18, and it can be done in the cyclotron, but DOPA, because of very poor patient, they don't want to supply for 1-2 patient. They don't want to create it. If you have a regular patient flow of 3, 4, 5 patient, or at least 2, 3 patient, then they can supply, they can make and supply it. So it has also a role to characterize the tumor, and we can see the synchronous tumor or other things. You can see that there is biochemical phenomena, FDOPA PET CT done, and you see that there is very good uptake and there is no background at all. So it is, there is no chance to miss the tumor actually. So gallium pentoxide 4 PET CT, this is also very novel agent and recent. This is chemokine 4X, it binds to chemokine 4 receptors which are overexpressed in aldosterone adenoma patient. So, and it can also easily be done where gallium generator is available. We can tag it with pentoxide. So in primary aldosteronism, what happens, that is increased aldosterone renin ratio, and there is chemokine CXCR4 overexpression. So for this, we can use this one. And in primary aldosteronism, there is two type of problem can occur. One is aldosterone producing adenoma and the aldosterone producing hyperplasia. In that case also, we can easily differentiate aldosterone producing adenoma by pentoxide 4, because other cortical tracer goes to and towards hyperplasia and adenoma. So this is primary aldosteronism, bilateral adrenal nodules are there. You can see that only this nodule is taking the uptake by gallium pentoxide 4. So for surgical management, it is very helpful that what adrenalectomy you can do. So you can easily if there is multiple nodules also, the nodule we are taking that uptake, we can remove that. Intermediate PET CT, I already told, this target adrenocortical enzymes, 11 beta hydroxylase or aldosterone synthase. Then it is specific, it is also specific for adrenal cortical tumors. There may be aldosterone producing adenoma or adrenocortical carcinoma. In both cases it is helpful, and it is alternative to AVS. But this is tagged with 11C, C11, which is also not commonly used, and because of their very less half-life, it is not feasible to supply from distant cyclotron. If in-house cyclotron is there, then 11C can be produced and intermediate can be tagged with it, and it is can be used. Okay. So this is a primary aldosteronism case, 11C intermediate PET CT done, and you can see this nodule is taking this one, and this is another case where bilateral adrenal hyperplasia is seen. So both bilateral adrenal hyperplasia and adrenal nodule adenoma can be diagnosed by 11C intermediate PET CT. Okay. So this is that summarization how we can look to the incidental, how can we there is workflow. So if typically benign, we can show that typical CT features, lipid-rich adenoma less than 10 HU CT, signal drop MRI, myolipoma also we can need microscope fat, cyst, fluid density, no enhancement, benign calcification. So in this, all these we can typically benign, no action is needed. If indeterminate 1 to 4 centimeter and indeterminate more than 4 centimeter. If indeterminate 1 to 4 centimeter, we can do NCCT, and if it is more than 10 HU, we will see that washout, CCT washout or MRI signal drop. If yes, there is more than 60% washout, it is lipid 4 adenoma, and we will do a follow-up. If there is no washout or no signal drop, so it may be a malignant pathology. So it may be metastasis, it may be pheochromocytoma, ECC, lipid 4 adenoma. So we will go for PET CT or biopsy or resection. Okay. Indeterminate, more than 4 centimeter, known malignancy. If known malignancy is there, then we do a FDG PET CT and do a biopsy. If there is no known malignancy, we can do a resection and biopsy, then PET CT. Or if there are other functional I am coming later. If it is functional adrenal tumor, then it may be pheochromocytoma, it may be primary aldosteronism, or it may be hypercortisolism. If pheochromocytoma, we go for DOTA PET CT or SSTR PET CT. If primary aldosteronism, we go for gallium pentixafor or 11C intermediate. And if hypercortisolism, we go for FDG PET CT or 11C intermediate. Okay. So these are the workflow generally, and thank you.
Thank you, Dr. Sahatra. So we will discuss everything during the panel discussion period. Now I would like to invite Dr. Puneet Sharma, who is the Chief Consultant Nuclear Medicine Department in Apollo Multispecialty Hospital. He will discuss about the newer theranostics and other applications of nuclear medicine in endocrine field. So over to Dr. Puneet Sharma.
Thank you, organizer, especially Dr. Roy, for inviting me, and thank you all for being here. So Dr. Satra and Dr. Dipanjan have made my task a bit easy as well as a bit complicated because they have covered most of things. So whatever is left, I will try to cover it up in this while. So what I will do is I will discuss about the nuclear theranostics. We all hear this word theranostics and what it is and how it can be useful in an endocrine practice. I will discuss that. And then I will discuss about certain other indications of nuclear imaging in different endocrinologic situations as we go along. So basically neuroendocrine tumor imaging and theranostics, and then some other indications in clinical endocrinology practice. So what is theranostics? We keep hearing this word. It is basically a combination of therapy and diagnostics. You can also hear words like theragnostics or radiotheragnostics. What we are basically doing is we are selecting a target in a tumor. It could be a receptor, it could be something else. Then we are using the same target for imaging as well as therapy. So the same molecular target will be used for imaging and therapy. And how would we do that? For imaging, we will use a diagnostic radionuclide, for example, a technetium-99m or gallium-68, which will emit either a gamma ray or positron, and then when you can use it with SPECT or PET imaging. And for radionuclide therapy, we will use a radioisotope which emits either a beta ray or alpha ray or Auger electrons, and then we can treat them. So with the same target we will do for imaging and therapy, and this forms the basis of theranostics. What it does is, since these receptors are specially overexpressed in only the tumors and very limited amount is overexpressed in other normal organs, so we can specifically target it and give targeted radiation doses, which is not possible with conventional radiotherapy. So that's the use. This is just an example of such a patient. For example, this is a patient with a metastatic pancreatic carcinoid. This is the gallium DOTA PET scan, which was the baseline scan. You see it's extensive metastatic disease to abdominal deposits, bone mets, lung mets, mediastinal nodes, and so on. Since there is this high expression of somatostatin receptor, we can use them for therapy. So what we will do is we'll administer 177 lutetium DOTA PET in these patients. So patient received this 4 cycles, and after giving 4 cycles, when we do a post-therapy scan, you see that tumor has responded quite well. This is not the usual response because usually there is a PR or CR, but this patient achieved almost near CR. So this is how theranostics work. I will come to it a bit later. So before going on to theranostics part, what I will do is give a brief overview of neuroendocrine tumor, because in endocrinology practice, you will see a lot of neuroendocrine tumors, especially if they are functioning. And such patient will come to you. You have to decide upon what the treatment will be and what will be the next line of management. So neuroendocrine tumors, as we know, these are very rare, but the incidence is increasing. Nobody knows why. Could it be because of we have better biochemical test? Could be because of improved malignant imaging modalities we have, but the incidence is rising. The origin can be varied. You can have a gastrointestinal or a pancreatic neuroendocrine tumor. You can have the lung neuroendocrine tumor, the quintessential pulmonary carcinoid. You can have a neuroendocrine tumor of unknown primary, where you have a metastatic neuroendocrine tumor, but you don't know where the primary is. And of course, pheochromo and paraganglioma, which are also a form of neuroendocrine tumor. The presentation of neuroendocrine tumors depends upon whether it's functional or not. Usually functional, that's the general dictum, that functional tumors usually come to the endocrinologist, and non-functional tumor usually go to a oncologist. Why is that? Because functional tumor, they are detected quite early. Since they are secreting peptides, the symptom appears much earlier. For non-functional tumor, however, symptoms appear much later. These are mostly because of maybe bleeding or obstruction or pressure effects. So by the time non-functional tumors are detected, they're usually grown much larger or either metastasized. But functional tumors, they will be very small at initial presentation, and imaging will be very crucial in localizing the tumor where it is. This is just an overview of neuroendocrine tumor pathology. Why it is important is, this is the WHO 22, because I don't want to go to the details, but like neuroendocrine tumors are either well differentiated or poorly differentiated. These are completely different variants. Many a times what we see is like we see Ki67 index, but the Ki67 index or proliferation or mitosis, there can be overlap between these two groups of tumors. It could be even well differentiated tumor can have very high Ki67 index or mitosis, while neuroendocrine, which is similar to that of neuroendocrine carcinoma. So this differentiation is totally a pathological diagnosis, and we have to differentiate between the two. Why we need to do that? Because the imaging modality which we are going to choose, the treatment the patient will receive, and the prognosis of patient all will depend upon whether it is a well-differentiated tumor versus where it's a poorly differentiated tumor. So this differentiation is very important. Now coming to neuroendocrine tumor imaging, so we have anatomical imaging, ULG, CT, MRI, and endoscopic ultrasound, and so on. We use endoscopy for luminal tumors and all. While anatomical imaging is quite useful in these tumors, and usually the one performed initially, what happens is, compared to other malignancies, the sensitivity of anatomical imaging for neuroendocrine tumor is much, much lower, because these tumors can have a very small bone metastasis, a small lymph nodal metastasis, which will not be picked up by conventional anatomical imaging and will need a functional imaging. So most of these tumors will end up having a functional imaging to accurately stage the disease or characterize the lesion. Of course, for functional imaging or nuclear imaging, we can have either a PET or SPECT. Mostly we do PET nowadays, because SPECT, as was discussed, is much inferior compared to PET because of a tracer as well as physical attributes. So for a neuroendocrine tumor, we have multiple targets which we can use for image. For example, you can use the glucose transporter for your classical FDG, which we use for other malignancies as well. Then we can target the SSTR or somatostatin receptors with a gallium labeled or F18 labeled somatostatin analogs. You can use FAPI, which is a fibroblast activation protein inhibitor for poorly differentiated tumor, which can be labeled with either a gallium or F18. For insulinomas, you can use a gallium Exendin 4, which will target the glucagon-like peptide 1 receptor. You can always target the norepinephrine transporter, which was classically done with the MIBG, which was the mainstay of imaging till a few years back. You can use the large amine transporters to target using fluorodopa, and for CCK2 receptors, you can always target with gallium minigastrin 5 analogs. Many of these are available, many of these are experimental. For example, DOTA SSTR imaging, FDG PET, FAPI, Exendin, MIBG, FDOPA is not widely or partially available, while minigastrin label, it's more of an experimental agent. But these are the modalities you have for imaging them. So now, again, moving back to pathology. So if you have a patient with a well-differentiated tumor, your first functional imaging will be a gallium-labeled SSTR imaging. But if it's a poorly differentiated tumor, you will do an FDG PET. So that's how the imaging modality choice will differ. FDG PET for well-differentiated tumor, we usually reserve it for high-grade tumor, maybe a grade 3 tumor, when DOTA is negative. If DOTA is very good positive, very high tracer uptake, we usually don't FDG PET. But for poorly differentiated tumor, there is no, even if it is a neuroendocrine, there is no role of SSTR imaging, and we'll do an FDG PET. SSTR expression, there are different SSTR receptors. The most common, which is used for imaging as well as therapy, are 2 to 5. So 2, 3, and 5. We can use it for imaging and therapy. What happens is, as the tumor grade increases, for example, in a low-grade tumor, it is about almost 100% SSTR expression. When in a high grade, it will be around 66%. So as the tumor becomes more towards lesser differentiation, the SSTR expression goes down. We have different tracers available. You will keep hearing these, which in your clinical practice are gallium DOTA TOC, DOTA NOC, DOTA TAKE, and some centers also are doing 18F labeled NOTA OC. These are all targeting the SSTR expression. So different centers have different peptides and they use different scan. What's important for us to understand is, from a clinical perspective, there is no clinical difference between all these two. So you can use any of them, it will go similar result. There are multiple studies I've done shown that everything is similar from a clinical point of view, no significant clinical difference. So you can either, so any form of SSTR PET based imaging, either a gallium labeled or F18, you can use it and there won't be much of a clinical difference. For example, in this patient, which we did for some thesis work, so if a patient has a tail of pancreas, non-functioning, NET, grade 1, biopsy proven, and it shows you the brown things which you can see are the very high SSTR expression. And the SUV max, which is a quantification of tracer uptake, it's quite high, it's 12.1. But for the metastatic lymph nodes, where you see that the tracer uptake falls down to 6.5, there the SSTR expression is much lesser. So as the tumor de-differentiates, your SSTR expression goes down and your DOTA tracers uptake also goes down. So this is the gist of it. This is a patient, some cases. So this is a patient with metastatic neuroendocrine tumor grade 2 non-functioning of the liver, biopsy proven. Now we don't know where the primary is. A CT scan was negative and was not able to localize the primary. So we did a DOTA PET and we can localize the tumor as shown by the arrow in a small pelvic ileal loop tumor. So this is the primary with multiple liver metastasis. Again, this patient, known tumor, multifocal tumor of the pancreas, CT as proven, then multiple liver metastases also seen in CT. But when you do a DOTA PET, you see that there are multiple bone metastases which were not visible on the CT. So it goes on, because if you were limited just to pancreas and liver, maybe you will operate the pancreas and do a tear for liver and that will be a good enough. But when you have so many metastatic, you will need some other form of treatment. That won't be an option for them. So the advantages of gallium-based imaging in neuroendocrine tumor is mainly for, not for liver or primary tumor. Of course, it can detect primary tumor when the primary is unknown, but the main advantages come in for detection of bone metastasis and significantly more number of lymph nodal metastasis. This is again a patient with gastrinoma, biopsy proven on endoscopy, a small duodenal lesion, and DOTA demonstrated a small paraduodenal node which was missed on CT, and no other metastasis. So this patient is amenable to surgery. This is a patient being treated for some time, unknown primary, non-functioning, and biopsy proven metastatic NET. And now the patient was being treated for a long time with octreotide analog, and then initially he was undergoing anatomical imaging, and this time he came for DOTA PET imaging. And what we were able to show that the primary tumor was a very small tumor in the colon, which was the primary, which was showing multiple metastatic site. Also, we were able to pick out multiple more metastases in the form of deposits in bilateral ovaries, which were not there previously. Now, this was the flip-flop I was talking about. So see, this is a grade 3 neuroendocrine tumor. So obviously, since it's a well-differentiated tumor, we go ahead and do a DOTA PET, and what we see is that the metastatic lesions are showing very poor tracer uptake of the DOTA, so very poor somatos. So this is a tumor have a higher grade of differentiation. So when we, in these patients, we will do an additional FDG PET CT, and when we do an additional FDG PET CT, you see that the lesions are highly FDG avid. So this is a poorly differentiated or high-grade tumor. This patient won't benefit much from either an octreotide or PRRT and will need some form of chemotherapy. So that's how you can kind of classify the patient into different treatment categories. And of course, the tracer uptake on DOTA PET has a prognostic impact. In one of our study, we found that if the primary tumor or a metastatic tumor, whichever had the higher SUV, as an SUV max of more than 14.5, have a much better prognosis compared to those with an SUV of less than 4. The higher the somatostatin receptor expression, higher the SUV max on DOTA PET, better the prognosis. So in clinical use, we use DOTA PET when there is a neuroendocrine tumor is suspected. So either there is an radiologically enhancing lesion, we are not sure whether it is neuroendocrine tumor or not, you can do it. Or if it's a biochemical suspicion of neuroendocrine tumor, then again you can do a DOTA PET. What I would like to highlight is that nowadays most of the DOTA PET imaging are done with a triple phasic CT. The entire CT gamut is done. So there is no indication of doing first a CECT and then again going for a PET CT. You can directly advise for a DOTA PET with a triphasic CT, and that will do it. Then of course in a known patient, you want to do a DOTA PET for a staging. Previously treated patient, you will do for restaging. In patient who has syndromic neuroendocrine tumor, for example, MEN1, von Hippel-Lindau, and so on, you can detect, because many of these tumors are neuroendocrine in origin, so you can use the same scan to image this patient. For example, a pheochromocytoma and a medullary carcinoma thyroid, or a gastric NET, you can image with the same imaging modality. In unknown primary neuroendocrine tumor, of course, you can use to localize the primary tumor, and of course we can use it for PRRT as I discussed later, for therapeutic decision with regard to it. And of course the findings are a prognostic indicator. Now coming to the therapy part, this term is the peptide receptor radionuclide therapy. So what we are doing is we are targeting a radiopharmaceutical to target specific peptide receptor, that is the somatostatin receptor. So this is the PRRT which we are using for treatment of neuroendocrine tumors. We have different therapeutic compounds. The most common and which is approved is the lutetium-177 DOTA PET. This is now FDA approved for treatment of neuroendocrine tumors. But there are other tracers which can be given on a compassionate ground or on a clinical trial basis. These include an actinium DOTA PET or a terbium-161 DOTA PET. The actinium is an alpha emitter and terbium is an beta and Auger electron emitter. We usually reserve it for patients who have progressed on lutetium, and then maybe we can plan for it. We can use this for treatment of metastatic or inoperable gastroenteropancreatic neuroendocrine tumors which are showing high SSTR expression, or we can use it for imaging of metastatic or inoperable paragangliomas and pheochromocytomas. Before I move on to therapy, I would like to just present one slide each for the clinical trials which paved the way for this use of lutetium DOTA PET therapy in neuroendocrine tumors. The first one was a NETTER-1 trial which was published back in 2017, where grade 1 or grade 2 metastatic NET which showed high SSTR expression and has progressed on octreotide alone were then randomized into two groups. One received high dose octreotide and one octreotide with lutetium DOTA PET, and lutetium DOTA PET group favored much better with an hazard ratio of 0.21. So there was a 80% reduction in PFS risk. And after that, it was approved by the FDA for treatment of grade 1 or grade 2 metastatic tumor which has progressed on octreotide. So this was the second line of treatment. Then came in the NETTER-2 trial recently in 2024, where it was given as a first line of treatment before octreotide. So in these patients, there is a higher grade patient with grade 2 or grade 3 which have a high SSTR expression. In these patients, lutetium DOTA PET used as a first line compared to high dose octreotide, and it was shown that the PFS was significantly higher for lutetium DOTA PET plus octreotide group compared to just octreotide group alone. And this is in the works, and possibly we get an FDA approval very soon. This is the first time that a radionuclide therapy has been approved as a first line treatment for any malignancy as of now. So how we do lutetium DOTA PET therapy or PRRT? So we'll do an SSTR PET imaging in all of these patients and show that there is a high expression of SSTR. The classical textbook definition is the SSTR expression in a measurable lesion should be more than that of the liver. Okay. In some poorly, if majority of the lesions are showing poor DOTA uptake, then we also add on an FDG PET CT. And if this patient have FDG PET CT is also showing poor uptake, then we can go ahead with this therapy. But if FDG PET CT shows higher uptake compared to DOTA, then these patients won't be suitable for this therapy. Then of course we will see for the hematological and biochemical parameters whether they are within the acceptable limit or not. The octreotide analog needs to be stopped before therapy. While this is not to be stopped for scanning purposes, there is no need to stop octreotide, but for therapy you need to stop octreotide. If the patient is a long-acting octreotide, we need to stop it for 4 weeks, and for a short-acting one for at least 1 week, but at least 48 hours. And of course you will, since a radioisotope, so we'll take all the radiation safety precautions and all. Another the problems which investigator initially faced with this form of therapy was this was causing a lot of renal toxicity. The reason for that was this lutetium DOTA PET is picked up by the proximal convoluted tubules of kidney and retained there and causes radiation damage. So different methods were devised how to, so that this tracer uptake in lutetium tracer uptake in the kidneys is reduced. So one of the method which was initially suggested and now widely employed is an amino acid infusion. So what we do is before we give lutetium DOTA PET therapy, so 30 minutes before we start amino acid infusion, and we continue this amino acid infusion around 4 hours after we have given the lutetium therapy. That what it does, it reduces the renal uptake and reduces the risk of renal nephrotoxicity. In all these patients, before discharge, we do a post-therapy scan to see that there is good tracer uptake in the lesions and there are no other unknown sites which were not previously seen on PET has been picked up, and there is no extravasation. So we do a post-therapy scan. So this was a scan which I showed earlier, a patient with metastatic pancreatic carcinoid, extensive metastatic disease on DOTA PET, very high uptake, so no need to an FDG PET. We give lutetium DOTA therapy. In the post-therapy scan as well, you can see there is high tracer concentration in almost all of the lesions. And then the patient received around 4 cycles of lutetium DOTA therapy, and a post-therapy scan was done after that, which shows almost near complete response. This is another patient, a 38-year-old male with metastatic paraganglioma. That was a carotid body tumor on the left side, which was metastatic to the left neck node, and there was a vertebral metastasis. So patient, since there was a high tracer uptake on baseline DOTA PET, the patient received 3 cycles of lutetium DOTA PRRT, and after that the scan was done, which is showing a good response. So the size of the tumor, the tracer uptake has significantly reduced. For the bone lesion, you can say the tracer uptake is reduced and there is sclerotic changes. So all that suggests a good partial response. Now coming to the alpha therapy or 225 actinium DOTA therapy, one of the major limitation of this is high cost and limited availability. The cost is many fold that of a lutetium DOTA therapy, and availability after the Ukraine war is reduced. Possibly it will resume soon. I am being told that by year end. Since this is an alpha emitter, so it gives a high radiation dose to the tumor. So that's the positive thing. Second, since it's a high radiation, the range of alpha emitter is much low. So the toxicities are, especially bone marrow toxicity and hepatic toxicities are less. And we usually preserve it for patients who have progressed on lutetium DOTA. First line we usually don't prefer to give. And around even for lutetium refractory patient, a large number of patients will show good response to this actinium DOTA therapy. Now coming to MIBG therapy, Dr. Santra discussed about the MIBG scan for all paraganglioma and pheochromocytomas and all that. So I will just discuss about the therapeutic part. This was the treatment modality which we had before the advent of lutetium DOTA therapy. Now this is an alternative treatment to that of lutetium DOTA in this patient. So we'll do it for all MIBG positive tumor, whether it's a pheo paraganglioma, either metastatic or inoperable. For pediatric neuroblastoma, we do it, and medullary carcinoma, thyroid, or carcinoid, when there is high MIBG uptake, in some patient you can do it. The response rate is around, for pheo and paraganglioma, it will be around 50 to 70% for MIBG therapy. When I say response rate, it means clinical as well as radiological response. The problem with MIBG therapy, just like for the scan, is there are a lot of drug interactions. So there, if I go to the list, there's a huge list of drugs which will interfere with the MIBG scanning as well as therapy, which include beta blockers, anticyclic antidepressant, this, that. There's a huge list. And before you plan a patient for MIBG scan or therapy, you have to check that the patient is not any of these drugs. The list is available on internet, but it's a huge exhaustive list. So that has to be taken care of. Second, since it is an iodine-based treatment, it's an iodine 131 MIBG which we are administrating. The free iodine can go into the thyroid and can cause hypothyroidism. So these patients are given a thyroid blockade with potassium iodide drops to start 2 days before therapy and continue for at least 7 days after the therapy. And since the radiation dose is high, the patient will require a prolonged isolation. Among the toxicities, just like hematological toxicities and all other can appear, but one important toxicity is an hypertensive crisis, because the MIBG will go into the tumor, cause tumor destruction, and all the catecholamine and other compounds will pour into the bloodstream and can cause a significant hypertensive crisis. So in a patient with a higher level of catecholamine level, we have to be very sure, we have to involve a critical care person and endocrinologist so that this crisis does not appear, because once it appears, it becomes very difficult to manage. So this is just one case, pre-therapy MIBG scan. You can see there is a large right adrenal mass, which is the pheochromocytoma, and there are multiple focal tracer uptake elsewhere, which are the bone metastasis. Now this patient received a 200 millicurie dose of iodine 131 MIBG. The second one is the post-therapy scan. You can show there is a good tracer uptake in the tumor and as well as other bone lesions. And since the radiation dose is radioisotope dose is much higher, many times, so you can pick up many other lesions as well, which were not there previously. And of course, when you follow it up with a post-therapy scan, you see after 2 cycles, it was done. And you can see that there is some response with a there is central necrosis is the primary tumor, and the bone lesions are much less visible. So there is a partial response. So this is the therapeutic part. So when I was discussing about the neuroendocrine tumors, one tumor which needs separate mention is insulinoma, because the traditional imaging modalities are not that useful in this subgroup of tumors. Insulinoma, as you know, is the most common functioning tumor of neuroendocrine tumor of the pancreas, and since they are mostly benign, you can cure it with surgery. But before surgery, you have to accurately localize it, that this is, and also numerize it, that that's the only lesion, there are no other lesion, because you cannot go and do surgery again and again. Anatomical imaging is usually first modality, and you can pick up tumors, but it has its own limitations because it cannot pick up small lesions. There are non-specific findings, and usually surgeons or endocrinologists prefer to get a functional imaging done just to corroborate it. Now, FDG PET CT has no role in benign insulinoma. Many a time we get like hypoglycemia, raised insulin for FDG PET. FDG PET has no role for benign insulinoma. Obviously, if there is a metastatic malignant insulinoma, FDG PET CT have some role, but nothing for benign. Then the one which we used to do previously very frequently is the gallium DOTA peptides, either a DOTA NOC, DOTA TOC, or DOTA TET. However, it has very limited sensitivity for localization of insulinoma. For other pancreatic neuroendocrine tumors, it's quite useful, but for insulinoma, it is not. In fact, in one of our studies, the sensitivity was much low, around 25% only compared to. But yes, if it's a malignant insulinoma with known metastasis, in those cases, DOTA PET is useful. The tracer which has come up now and now being more and more used is gallium Exendin. It is usually preferred for imaging of a benign or suspected insulinoma. So this is a patient, this is the post-op, it was post-optically confirmed to be a multifocal insulinoma of tail of pancreas, but pre-operative imaging including gallium DOTA PET were all normal. So this highlights the limitation of gallium DOTA SSTR based imaging for benign insulinomas of pancreas. Then again, as I told, for malignant insulinoma, DOTA PET is a good choice, and it can show high uptake in the primary tumor, the metastatic liver lesions, as well as metastatic lymph nodes. Exendin PET, so what it is, what Exendin does, it targets the glucagon-like peptide receptors on insulinoma, which is hyper-expressed in insulinoma. For benign insulinoma, there is a very high expression of this peptide receptors, and that can be targeted for imaging. In a meta-analysis by Shah et al., the sensitivity and positive predictive value was almost 95%. So if you have availability of Exendin PET, that should, for insulinoma, especially benign insulinoma, that should be your functional imaging modality of choice. And of course, it is superior to gallium DOTA based imaging. Of course, there is a limitation, for example, malignant insulinoma. Again, this is in contrast to DOTA SSTR. For malignant insulinoma, Exendin performs poorly. And of course, you can have false positive findings, like for example, Brunner glands or non-specific pancreatic uptake, which can confuse. But over and all, Exendin PET is a good imaging modality for known or suspected insulinomas. So this is a patient with a tail of pancreas insulinoma. This was seen on CT as well. So just to confirm it, they did a Exendin PET. So on the tail lesion, you can make it out. It's showing high Exendin PET. What it picked up was another lesion in the body, which was not seen before. So if you have gone ahead and just operated the tail, the symptom would have recurred. Now you can address both. So multifocality of an insulinoma is very, very common, especially once you do more and more Exendin PET, you will realize that it is much more common than was previously thought. And ideally, it should be done whenever it's feasible to get it done. Now, moving on to from insulinoma, we'll talk about these rare scenarios, the tumor-induced osteomalacia. Generally, these patients present with osteomalacia. The cause is not found, patient is symptomatically treated, they have multiple fractures and so on. This is basically a paraneoplastic syndrome which is caused by benign tumors which secrete the peptide FGF, fibroblast growth factor 23. What this factor does is it inhibits your renal absorption of phosphate and causes phosphaturia and thereby causes osteomalacia. And if you can localize these tumors and operate it, the patient will be cured. So patients who have been suffering from many, many years, if you can localize the tumor and get it surgically operated or treated, patient will be cured. So in this scenario, gallium DOTA PET CT has shown to be very useful. anatomical imaging does not have much of a role. Gallium DOTA PET CT is useful, and around 65 to 70% of these patients you can localize the primary tumor. An important thing just to add is in these tumors are often hidden very rare site. For example, by the heel, in the mastoid, maybe by the head of scapula. So when you are ordering or requesting for a DOTA PET scan in these patients, you always request for a head to toe scan so that nothing is missed. This is one such patient. He was being treated, managed conservatively, had fractures, repaired. This was, I think, 8 years he was going on through it. Then someone, endocrinology colleague only, they got hold of an article in NEJM and then requested for a DOTA PET, and this DOTA PET shows as tumor which was seen in the sacrum. You see in the CT image you can hardly make out anything, but this is a tumor. It was then biopsied and operated. It turned out to be a hemangiopericytoma which was causing this femur, and patient after operation within 3 months patient significantly improved clinically. Then another rare scenario which we encounter is ectopic ACTH syndrome, when there is a non-pituitary source of ACTH secretion and we don't know where it is. And in most of the circumstances, it is a neuroendocrine tumor, mostly of either lung or pancreas, which are secreting this ACTH and causing hypercortisolism. The problem with anatomical imaging is these tumors are sometimes very small and either can be missed or the findings are considered to be non-specific. For example, many of these patients will undergo a CT of the chest and it shows a very small nodule, but we are not sure whether that is the cause of ACTH secretion. And in this situation, gallium DOTA PET CT has been shown to be useful and have a higher sensitivity of around 75 to 80%. And also specificity, because if you pick up a nodule on CT, we are not sure if you can show that it's a high DOTA PET tracer uptake in that nodule, then you can confirm that it's a neuroendocrine tumor and then address it accordingly. This is one of our cases. So it's a very small nodule, ectopic Cushing syndrome, very small nodule, we are not sure what it is. In this patient, we did an FDG PET as well, but FDG PET was negative. So we went ahead and got a DOTA PET scan done, and you can see there was a high SSTR expression, somatostatin receptor. So this is a neuroendocrine tumor. This was then VATS operated and found to be an pulmonary typical carcinoid. So in conclusion, nuclear imaging and theranostics can play an important role in management of, especially for rare endocrine tumors. And before we plan for any management, appropriate functional imaging modality is essential, and we have to decide it based upon all our knowledge and information so that we can get an optimum result. And many of these either diagnostic scans or therapy require specific precautions. Preparation, we need to be aware of them before we advise for them. And of course, whenever you are in doubt, you can always reach out to us. Thank you for it.
So thank you everyone. Just now I like to call our esteemed speakers. Please come here for panel discussion. And anyone, if any question in your mind, you can ask our esteemed speakers. Definitely we'll try to give your answer. So please feel free to discuss everything and any question, please.
So, hello. My question to Dr. Dipanjan Gupta. So, in case of retrosternal goiter, mediastinal tumor, which modality of thyroid scan you will prefer? Because in technetium scan, the image is not clear. So, which modality of scanning you advise?
Ideally speaking, it has to be done on Iodine 123 MIBG, Iodine 123 scan, but then this is not available. So I think we have to resort only to technetium scan as of now, and maybe a proper CECT study, because if it is that will anyway clearly show the goiter going inside the mediastinum.
It is still valid because we have CT as well. So unless it is completely studied with liver metastasis, then we are able to find out normal liver parenchyma, and more or less it's like a more of a visual thing rather than a semi-quantitative thing. For lutetium dotated therapy, so we usually give either 4 to 6 cycles and then we keep them on octreotide follow-up. So unless the patient is progressing on it, we can follow them up. The second thing is there are some papers have come in. For example, a patient had a long progression-free survival after giving. If it's still SSTR expressing, then we can retreat them with lutetium dotated with good results. For MIBG therapy, it's a bit different because MIBG, there is no standard protocol what to give. So what we usually do is we give like 2 or 3 cycles at around 6 weeks, 6 months to a year, and then follow up. And after progression, if the patient still doesn't have many other options, we can again retreat it if it's still MIBG concentrating. The key point is should be MIBG concentrating, and then we can retreat them again.
Thank you so much, sir.
Right.
Last question. Maybe.
Sure.
So, are you using Exendin for insulin also? Is it available?
Yes.
Yes, we are on.
So, Dr. Puneet,
Hello, my question to Puneet Sharma. In case of insulinoma, endoscopy, ultrasonography is sufficient to localize the tumor. So when will you go for Exendin scan?
Our gastroenterologist goes for all patients because as I showed to you, if it is so okay. Our gastroenterologist goes for all the patients because you can miss multifocal tumors and tumors around the tail, which often tend to be might not be that well depicted with ultrasound. So for our most of the patient will do
So
Exendin.
multiplicity is only around 10%. So not all.
That is what we had like pre-Exendin era, right? Now with that number will be a bit more. What we are seeing is it will be around 20. No, we are not done too many patients, but it will be around 20-25% if I am not wrong.
is there?
So you spoke about endocrine graves at the time period when actually developed. What was the time period? So usually follow that.
That is variable for patients to patients. I mean, then what we have seen is when the patient classically fits into the pictures of, say, a Graves, see, clinical thyrotoxicosis or biochemical thyrotoxicosis, you do a scan. So what are you going to expect? Either you are dealing with a subacute thyroiditis, number one, or second is you may do a scan in a phase of resolving thyroiditis, which I have not shown. That's why TSH is important. You may get a normal or near normal uptake. But then if you see increased perfusion, as I said, with not so high uptake in the thyroid scan per se, we say possibly we are dealing with a case of developing Graves' disease or hyperthyroidism, to be precise. So if you follow them up and with the serial TSH, not the scan, you will gradually, we have seen that the TSH really does not come down. I have seen recently a patient who has developed a frank Graves after 6 years. Recently I saw a young female who has been on conservative follow-up with only TSH, her TSH has never gone up, but she was not given any she was not prescribed any anti-thyroid medicine per se. Now that she is married and she wants to conceive, the endocrinologist has sent for. So this time period, it is nothing like that 6 months or 1 year. So it may vary. But what I was trying to tell is, if we see such kind of a scan, we shouldn't jump saying that it is a normal tracer trapping. Even I have had some conversations with my endocrinologist colleagues. At times they say, if we report a normal trapping function in thyroid scan and their clinical suspicion is Graves, they consider this to be Graves.
One point we want to make here, that any patient, particularly when the TSH is low, T3, T4 is normal, and from endocrinologist perspective, if the uptake is more or less normal, in that case you can go for ultrasonography, and if you see the vascularity of thyroid parenchyma is increased, it favors Graves. So there are some situations where we are a little bit in confused state. So I think that will be a better, good idea. And definitely the perfusion imaging is a new learning to us. But this is also a very important element. So from any question, yes.
Hello. Sir, I am Dr. Akshay from Care Hospital, Hyderabad. I just want to add one comment that we have experience with 18 of fluorochlorine. We could not find with ultrasound and Sestamibi was negative, but with fluorochlorine CT, PET CT, we found one patient intrathyroidal parathyroid adenoma and another patient retropharyngeal adenoma. So I just wanted to share. Thank you.
That's a good point.
I'm Siddharth from Ramaya, endocrinology resident. I have two questions, sir. One is, what is the implication of somebody who's already on, say, calcitonin and calcitriol with respect to diagnosing with the MIBG scan for a possible primary hyperparathyroidism? Like sometimes they say that there can be some decreased uptake. So is there any specific scenario where we are supposed to withhold that for a few days and do a rescan if the initial scan was not showing?
No, not required.
Okay.
There is no such, at least no such guidelines.
The active vitamin D, they can continue. I mean, if somebody has been put on that. And the other thing was, like in a patient of hyperthyroidism, if somebody has already started antithyroid drugs outside and the TSH is currently not in a very low level and you want to do a imaging to confirm the diagnosis, do you need to have a specific lower limit of TSH before we subject them for a technetium uptake scan?
No, not really, because depending upon how many days the patient is taking the 18 antithyroid medicine, most of the time, even if they start and then in a few weeks time they come to somebody else, even if you perform the scan, it will show up. I mean, it will show up because the scan doesn't normalize in a jiffy, you know. I mean, it really takes time. So is the TSH. Unless somebody is being treated for a longer period of time, then anyway as a clinician you would like to, and you are in a doubt, for example, because I believe you are thinking of a patient wherein if there was a clinical thyrotoxicosis, he or she was given an antithyroid medicine without any further investigations, and now the patient has landed up to you and you want to be sure. So if it is a Graves, so with a few weeks of ATD will not change much. But then of course we see, that's why we insist on doing a TSH. And I have seen patients with 2 weeks of pneumocortisol TSH is 28. I think I did the scan last week, and we saw increased stressor uptake in the entire thyroid. That TSH had helped me to tell that this is not a Graves. There is a term called TSH-induced hyperstimulation of the gland, which is causing increased uptake. So that is how you have to balance.
We do not know the endocrinologist whenever send a patient to nuclear medicine specialist, they sometimes ask to stop mathematics. And suppose a patient who is extremely in situations, little bit in a crisis, or in that case, proper differentiation, is it necessary at all? The technician what we are giving is not organified. So we just want to see whether the NIS is upregulated or not. But why if people are asking that you have to stop carbimazole and then you have to go for scan after 7 days?
That is a big time debate. I mean, in most of the endocrinology, I remember ITSCon 2014, there was a debate for 10 minutes on this. So this is what is in the guideline, and we do ask to stop neomacazole at least for 5 days, not 7 days. Sometimes 4 days is fine. But then in this particular context, if the patient is so toxic that you really cannot stop the medicine, the scan will actually give you the answer. I mean, even if you don't stop. So that is the practical. I would not like to, handle a toxic crisis patient in the department. Nobody would like to. So, I mean, the clinical endocrinologist will not send for the scan in that case. So I think we can do if the patient is bothered, but normal dictum, and in all our guidelines it is mentioned that we have to stop. So we follow this.
I think if I think of iodine therapy, definitely it has to be stopped, because in that case we have the agent should be organified. But if we are not, but if
on therapy, the NI is down regulates also. That's why.
If I want to give therapy, say a patient presented with grapes, then we have to stop. But if we want to diagnose this patient, whether the patient has been suffering from MNG or from grapes or maybe Savacote thyroiditis or maybe painless thyroiditis, then I think it is not necessary to stop drugs. We can go for.
Guidelines say that we have to stop for at least 3 to 5 days. We have to stop it. We have done patients without stopping when the patient is very toxic. You get it, but so there is, I think, with prolonged neomacazole or any kind of treatment, there is down regulation of the NIS. Suppressed. So if it comes out again borderline on the image, then we are again in the soup.
Hello, good morning, sir. I'm from IMS BHU Varanasi. Sir, we had 2 patients of primary hyperaldosteronism. The screening test was positive. The confirmatory test was also positive. We did the adrenal CT, so that came normal. So next to our institute, there is Tata Institute, Cancer Institute, and from there we did the gallium-68 pentoxaphil scan. And for 2 patients we did, and sir, in both the patients there was no uptake. Recently also, sir, last month one patient was there and 3 months before. This was the first pentoxaphil scan which was done in UP. We only, sir, advised that. But now how to approach that, sir? If that scan is coming negative, CT is also negative, and patient won't agree for ABS. So it's a very difficult situation. Anything else or what we can go for then, sir?
It may be because pentoxaphil is specific for aldosterone adenoma. So it may be diffuse hyperplasia may be the cause. So what should be done?
So have you read the recent guideline regarding the primary aldosteronism?
Yes, sir.
So as per their statement, it could be negative, it could be positive. Even that it is negative, then go for just a trial of mineralocorticoid antagonist,
yes.
and then you just look for the response. And if you see the patient, the blood pressure is controlled in a good way, good fashion, then you should continue mineralocorticoid antagonist. And maybe later on period, you can go for anatomical imaging, and then again can go for PET imaging. Okay. But adrenal venous sampling is not a good test in these days, because they are not giving any importance on the ABS, because it is a little bit tricky to do adrenal venous sampling. Okay. So in that case, it is better to trial for.
The first patient we have started, but second was a young female, so we thought that what should be the approach.
Okay.
So the role of pentoxaphil is to differentiate between surgical management and medical management.
Okay.
That's its only role. There is no role in diagnosing. So if you have a unilateral adrenal adenoma or a unilateral hyperplasia on pentoxaphil, you can think about going for surgery. If it is not there, then you'll have to continue with it. But that's the role of pentoxaphil rather than a diagnosis.
Thank you, sir.
Nice discussion. Regarding parathyroid imaging, we know if you do multiple imaging, structural and nuclear medicine imaging, there is incremental gain to detect more number of parathyroid adenoma. So if we don't want to miss parathyroid adenoma in a suspected case of young hyperparathyroidism, primary hyperparathyroidism, what will be the basic structural imaging and nuclear imaging? So one ultrasound and one nuclear imaging Sestamibi scan will suffice, or 2 at least structural imaging, or 2 nuclear medicine imaging. So what will be your point?
I mean, it all depends on what you are getting. There is an algorithm if you want to follow. I mean, there is no standard algorithm, so to say. The USG remains the first modality of choice, no doubt about it. And the second modality of choice is Sestamibi. It is not only about the, what is the best. You have to also see what is available. I mean, Sestamibi is now available in most of the centers in most of the cities. So Sestamibi should be the second investigations of choice. The next line of investigations come. Now, if the Sestamibi shows something conclusively, then generally these days people are doing a 4T CT. And if it is concordant, they are going ahead with the surgical management. Only thing is, if the Sestamibi is negative and your clinical suspicion is high, then the question of all these gallium, trivahexene and fluorocholine, whatever is available in your center, so that comes in. I mean, they are not the first line investigations. I mean, because now primarily because it is not available in every place, and second is cost. So, but then of course, as every one of us say, that any PET scan image is better than a SPECT. So if we compare MIBG versus choline or trivahexene, it would be better. So maybe there will be a days when this will be used as a first line.
Thank you.
If it is available.
If you have trivahexene PET CT available, then that will be the modality of choice. It will be cost effective, it will save patients time, and it will avoid unnecessary surgeries. At this point of time, we don't have wide body of evidence, but whatever practical experience we have, whatever, in few years, like an ASECON, few years later, we will be discussing that it become the modality of choice. Because you do it with, what we do is, nowadays we are still doing for maybe negative patient only we are doing trivahexene. But whenever we are doing it with a 4D CT. So a trivahexene PET with a 4D CT will be very good, and I think with time you will see that it will become the modality of choice.
Sir, I'm endocrinology resident from Calcutta Medical College. So I had a question, a bit extension to the pentixafor question that somebody else has asked. As sir has mentioned regarding the latest guidelines in regarding primary aldosteronism, so I want to share one patient regarding which the confusion came up, that their patient had biochemically confirmed primary aldosteronism, and there was high probability of lateralization as well, all the criteria that regarding age and the biochemical values. And the anatomical image did show lipid poor lesion, but there was some issues regarding his renal function. So the intervention radiologist did not give, say, they don't go for AVS and all. So we didn't go for that, and we went for pentixafor. So it showed no uptake. So there was high degree of chance of lateralization, as you have mentioned, sir. And we were suspecting it to be a unilateral disease and going for surgical management. But somehow because of that, we could not perform AVS for a different reason, but could not also, the pentixafor did not show any result. So in these cases, again, should the medical management be tried once again, as sir has mentioned, or there is any other way we can find it out?
For practical purposes, you will have to continue with them. Unless you are like so sure that it is a lateralization, the only way to prove it, you remove the adrenal and then see that's not feasible. So you continue with that. It's like pentixafor is the basic gatekeeper between medical management, as I told you. So I think you will continue with
just adding to that, I have seen certain studies where they have compared, done outside India, maybe I just don't remember, they have compared pentixafor with adrenal venous sampling. So can it be commented that it is better, so we cannot?
Yeah, there are some studies that are showing it is superior and some showing it is non-inferior.
Okay.
So it is at least as good as AVM.
Okay.
So,
okay.
Just one important point here, that the lesion which was detected in the anatomical imaging,
yes, sir.
what is the size of the lesion?
Sir, it was around 1.9 centimeter if I correct.
So if it is around 2 centimeter,
yes,
from endocrinologist's perspective, we
yes,
have to exclude also Cushing's. So if
yes,
it is Cushing's maybe, if it is the subclinical Cushing's, in that case you have to go for DHS maybe.
Okay.
And maybe if it is Cushing's and if the other parameters are suggestive, in that case maybe you have to go for surgery. So otherwise, if it is isolated primary aldosteronism,
no, sir, it was actually that part was evaluated.
Definitely we should do. Yeah.
And sir, another I have got a very basic question. Actually, sir, is there any protocol for management, glycemic control before doing FDG PET CT scan? I mean, an uncontrolled diabetic patient. If whether there is any modality, I mean, guideline or anything like that, sir.
Yeah, for FDG PET, what you need is the guideline advice, fasting blood sugar at the time of injection below 200. Okay, preferably below 150, but below 200 you can do. That's what guidelines say. The fasting is preferably 6 hours, but at least 4 hours.
Okay.
Even patients who have a bit higher blood glucose level, some people they advocate use of insulin, but what you can do is you can give SGLT. Okay, and after 1.5 hours, that does not interfere with the FDG uptake. Give it at 1.5 hours, you can measure the blood glucose. If it's below 200, you can well go ahead with it.
Okay. Thank you very
Very
much.
practical point I must tell you that this, if you tell your patient that you come with a less than 200 blood glucose level, they'll end up into 220, 250. So, and then at least for practical purposes, we have to understand, at least in the city of Calcutta, when we place an order of FDG, we do a prior order. So we order it today evening for tomorrow's patient. So we have seen, because when the patient comes up and if we say we cannot do the scan, nobody is, when there is a confusion, who is going to pay for the radioisotope, you know? That is why we are very strict about it. And 4 hours and 6 hours fasting, for that, I don't know, I have my reservations. I have always seen very poor quality of glucose uptake in patients. Even a doctor's father, we did a PET CT scan, I found a very bizarre uptake. And I was looking for a clue. And repeatedly I kept asking him that, what have you consumed anything? Then after a lot of probing, he said, I took 2 spoons of payasam in the morning. And then I had no option but repeating his scan, and his scan came fantastic next day. And this GLUT receptors expression and the homeostasis of GLUT receptors is very unpredictable. So I in my practice I'm very, very strict about the glycemic the instructions. So even if it sounds a little prohibitive, but then I follow it because I have the best chance of giving one injection, and generally I've been practicing for more than 15 years now. So seen patients do follow 1 or 2 sporadic, and endocrinologists are quite good in managing the glucose control. So maybe there is 1 or 2 exceptions. In those cases we have a better molecule now, FAPI, to do. So because FAPI is one PET CT which is alike FDG, gallium labeled FAPI. So in this case you don't need this glucose control.
And you have raised about the FAPI. So could you just share with us some experience regarding the PSMA or FAPI, particularly in TENIS, where the thyroglobulin is elevated and there is no iodine uptake? And is it actually available in Kolkata or not?
No, let me just, so PSMA is not in this context. PSMA is prostate specific membrane antigen. So when you do a PSMA PET, it is only in the context of prostate cancer, no other indication. Yes, there are some meningioma, there are some other indications, not for the endocrine. FAPI is a molecule which is like almost in conjunction with FDG because it goes and binds to the tumor stroma of the cancer, the fibroblast activate protein inhibitors. So it is used in many cancers these days. But the major indications are cancers which show poor FDG uptake, like all mucin secreting cancers, like stomach, ovary. All these cancers do not take up good amount of FDG. The results of FAPI is promising in those cancers. Some are claiming that in all other cancers like breast and lung, FAPI is equally good, and we are seeing those results in our conferences, in our publications a lot. But as of now, the mucin secreting malignancies, FAPI results are more promising.
There are recent papers are coming which showed that the PSMA is actually expressed more in case of dedifferentiated thyroid carcinoma. So it is the most, because PSMA was done at a random fashion in our country, and it is particularly for the prostate carcinoma. Maybe there is days are coming when we do see patients with TENIS. We can go for PSMA, and maybe we can go for PSMA and FAPI both with the dual.
PSMA for apart from in other cancers, apart from prostate cancer, the way the PSM expression is seen is because there is new vascular fiber. So the expression is on new vasculature, not on the tumor cells. So that is unlikely to be very beneficial for therapeutic purposes. FAPI, it is expressed on the tumor stroma. So in dedifferentiated thyroid cancer, as you pointed out, there is a role of FAPI. Some studies have shown it to be superior to FDG, and there was multiple papers, including papers of AIMS Delhi, which have shown that FAPI-based therapy can be used for iodine refractory thyroid cancers as well. So, but that totally depends upon how the FAPI expression. If it is very high expression, then only we can go ahead with it. Otherwise, it's not possible.
So initially, in our 20 days, we are discussing about the redifferentiation of the thyroid carcinoma, and somehow it was not discussed in these days. But recently, there are papers are coming where we can give some agents by which we can go for redifferentiation. Your message?
Yes. So redifferentiation of thyroid cancer is now a reality, but in Western countries, because the TKIs which are selmetinib, I don't remember the tropotinib and all. If they have this specific mutation, you can give them and the radioiodine uptake is restored. But those are very costly, like in 30 lakhs, 40 lakhs for that short course of maybe 10-15 days, and not available in India as of now. The moment the generic version will come in, which I hope soon, we will use it regularly.
I distinctly remember there used to be almost 13 agents considered for redifferentiation therapy. I remember because this was a DNP question. So it was a 10 marks question, redifferentiation therapy, and there were so many agents which were under discussions, but most of them have not proven much beneficial. Now the TKIs are good for so many things, but there's, as Puneet is saying, these are so expensive. Of course, everything that comes new is expensive, and with time it will come into the clinical foray.
Any question from audience? Any comments? So just before conclusion, I want to share two cases here. Recently we got in our institution in argument. So patient presented with, referred to us, patient was evaluated outside for PUO, pyrexia of unknown origin. And as the recent guidelines said that initial parameters if normal, then you can go for statewide PET scan. And PET scan showed there is a bilateral adrenal mass. And then the patient was referred to Tata Medical Center, and then the biopsy was done, and the biopsy revealed nothing. And then some of our colleagues, they sent to us that this is an adrenal problem, just deal with adrenal, we have no problem at all. Now when we saw the PET scan showed that there is a bright adrenal mass, big mass, but actually whenever we saw the patient initially, the diagnosis was done within 1 second. The patient is pigmented, and the patient's blood pressure is low, and sodium is in the lowest, and potassium is in the high range. Though the cortisol level is the normal, but the ACTG is high. So this is a condition, it is called evolving adrenal insufficiency. Cortisol may be normal, absolutely normal. It may be 10, it may be 12, but if you do a paired ACTH sample, ACTH will be above 100, 200, 300. So in that two cases, the ACTH was around 500, 540, and 600. So we just examine the patient clinically and we go for biopsy with fungal and TB gene expert. And in both cases, we got histoplasma. So this is also in the other hand of the nuclear scan, that always we are not dealing with the tumors. We are not dealing with the functioning tumors or non-functioning tumors. Maybe some granulomatous disease, they can present with like carcinoma. So check patient properly, clinicians, idea is the first one. If you see the pigmentation is increasing and the low sodium patient is complaining of hyponatremia, think about primary adrenal insufficiency first, then think about carcinoma. But though we know that the primary tumor there will be a bilateral adrenal metastasis, and they can very rarely present with adrenal insufficiency, but this is very rare. But the common one is the TB or the histoplasma or the fungal infection.
Any reason this histoplasmosis is common in the ganglion?
Yes. Because we do not know.
Bhartiya's first paper.
Yeah.
Any reason we don't see in South?
Exactly.
Something to do with Ganga?
Of
course, it is written in
Sir,
the
yes, sir. In the 878 and 84, there are two papers published from the School of Tropical Medicine, and they said that their particularly in this belt, the histoplasma is much common. And recent paper showed that the adrenal, if we got any adrenal mass, infiltrative lesion, TB will not be the first one. First one is the histoplasma. So we do not know, maybe there are some environmental factors are going on. But with this, I like to conclude this session. Thank you very much. Sir?
You said you had 2 cases.
Yeah. 2 cases, 2 consecutive cases in 2 weeks. Yeah. Sure. Thank you very much.
So, an excellent session we have had at the beginning of ACCon. So, I would request everybody to please collect their workshop certificates, those who have participated in this nuclear imaging. From our chair, moderator sir, Dr. Ajit sir will be here. So, those of you who are here, who have participated, given names in this, please do come and collect your certificate. Sir will be distributing them. There are plenty of names, so can you please volunteer yourself, and those who have
Okay. Just sit down.
okay.
Instead of you calling,
Sitting with the waiter.
we'll pick up on the way.
এখানে রেখে দিন যে আর যেন নিয়ে নিক নাকি ওকে So please collect your, yeah. There are plenty of certificates here. Just collect from the desk where the papers are here. Just collect your certificate from.
Sir, আপনি কল করুন নাকি আমি কল করব? So I'm just calling up the names. Please do come and collect it. Anne Elias, Akshay Khatri, Balekara Srikant, Bhanusri Kalava, Bhanusri Kalava, Chandramouli, Devender Kumar, Harshini Sompalli, Sheikh Mohammad Tahsin, Janvi Shah, Archana Rao, Orundhati Das, Ajit Jagtab, Akshay Narayan Ambedkar, मैक्सिमम नहीं सर. Anita Sebastian, Archana MH, Arsad, Ayush Agarwal, Bathula Sai Vargava Chaitanya, Bhupesh Kumar Yadav, Amulya Reddy, Divya S, Harini Jayaraman, Jagriti Nandwani, Girish Kumar Sharma, Venugopal Reddy, Kavya B. Khoranpur, Mangesh Pathade, Megha Majumdar, Mukesh Kumar, Nithu Joy, Olivia Bhattacharya, Vardhan Kumar Reddy, Mukesh Kumar. Rameshwari Rajendra Chakole, Namrata Goginemi, Shayantan Chakraborty, Sneha S. Bhujle, Shubhankar Roy, Thusara Nayani, Kanimoji J, Aravind Kumar, Manjunath Totaganti, Milin Gaikwad, Naga Bhagyashri Mangam, Nikhil Sanjeev K, Palla Sairam Samdeep, Pushpa Panchinemi, Rishav RK, Sanjana JM, Siddharth Sadananda, Siddharth, Snehashish Paul, Shuyash Gupta, Vinay Prasad. Thank you, everybody. Yes, nuclear imaging. Yes, registered here only. আমিও দিয়েছিলাম কিরকম সব মারি কাজ Just wait, I'm just waiting. হ্যাঁ স্যার বলছি যে ওই দিয়ে দিলাম যারা যারা ছিল তাদেরকে দিয়ে দিলাম অনেক ম্যাক্সিমাম কেউ ছিল না তো ওটা কোথায় রাখবো 1 নম্বর নম্বর আর 2 নম্বর স্যার ওটা একটু অ্যানাউন্স করার ব্যবস্থা একটু করে দিতে হবে এখন যে যারা এই যেটা যে নিজেদের যেটা পার্টিসিপেশন নেবেন এরপরে হয়ে যাবে আসলে আরেকটা স্যার বলছি আচ্ছা ঠিক আছে ঠিক আছে ঠিক আছে আর হচ্ছে স্যার দুজন এরকম আমার কাছে নাম বলছেন যারা ওই এটাতে রেজিস্টার করেছেন ওদের সার্টিফিকেট নাম আছে করা যেতে পারে
প্রাইমারি হাইপারেটের ব্যাপারে তো কনফিউজিং আছে আমাদের
সম্ভবত তো আছে তো Good afternoon, everybody. Welcome to ACCon after on the day, first day and the post-lunch session. So we are going into our next workshop, that is on diabetic food, and it's a 3-hour workshop where we have got multiple speakers and multiple lectures. So as a chairperson and moderator of this session, I'd like to invite Dr. Arijit Singh sir, who is currently the Assistant Professor of Department of Endocrinology in IPGMER. Sir, please. And sir will take the session forward from here.
So thank you for the nice introduction. So I'm proud that in this workshop, that particular diabetic food workshop, maximum registration has been done. It is important for the clinical practice and also from the exam point of view. So the diabetic foot is very important topic, and we know that in every 20 seconds, anywhere in the world, one amputation is ongoing. In human evolution, around 2 to 4 million years ago, the humans became obligate bipeds from the facultative bipeds. And for this reason, the growth of the calcaneum is very much important. Usually the 3 longitudinal arches, which is usually develop around 10 years of age. So we will, in the next few hours, we will discuss about the diabetic foot, its pathophysiology and management. We have several eminent speakers amongst us. I will first invite Dr. Felix Jevasing, who is an professor in the CMC Fellow, Department of Endocrinology. He has done several work and research on diabetic foot, and also he has done several publications regarding this. I will invite Professor Felix Jevasing to deliver his presentation. Thank you.
Good afternoon, everyone, and thanks to the organizers for inviting me for this talk on for the workshop on diabetes food, and thanks to the moderator for the introduction as well. So, I'm so sorry. So, if you look at the diabetes food, it's important to understand about the biomechanics. And suppose if someone asks what is biomechanics exactly, is actually if I'm standing here, that means all my force is actually going down from top to bottom in associated with your BMI and also with gravity. So it is actually a multi-dimensional force which is exerted on the foot. And actually, if you look at carefully, the only palpable organ which you can actually look at in diabetes complication is the foot, where you can actually palpate it. I mean, if you look at thyroid, at least it's deep down inside the fascia and deep down inside the muscle, but the foot is probably the only area where you can actually see and palpate it much more in depth and give some diagnosis. And the second very important is that ankle, and whether we like it or not, the ankle joint actually has the most stressed joint of a whole body. Whether they are obese or lean or walking or jumping or diving across the two logs of wood, wherever, it is actually the ankle joint which is actually very important in terms of the stability. If I'm standing here, stability, it looks, and propulsion when I jump, and also when I walk or run, have a mobility, and definitely there is a protection because uneven parts, if I walk, so there should be some three-dimensional changes. Don't worry about all these jargons because this is all we learned during our anatomy days. It's nothing new I'm going to talk here. And so what happens exactly is the skin that is changed. There is muscular changes, there's vascular changes, and neurological changes. That means you put it in a simple way. So these are the 4 changes happens in diabetes which actually have an impact in the joint. Looks like proprioception or joint position, etc., have several changes. So, I mean, I'm not going to the detail of the bony architecture because there is a radiologist expert here who will talk about this. And we have at least 26 bones and 2 sesamoid bones. Someone can have 3 also. I may be having 3 because I never did my foot x-ray ever in my life. So maybe having 3 as well. So these are the small bones which actually talk to each other and align in such a way that it maintains the architecture. I mean, as the moderator said, the arches of the foot. So it maintains the arches of the foot such a way that someone walks, jumps. I mean, it's for the normal people. But what is happening in patients with diabetes, what we are going to talk about it in the next few minutes' time. So this is the sagittal section. You can see that what exactly the bones are. I am not going to the deep. If you are recollecting your anatomy knowledge, we all say that there is plantar aponeurosis. We all think that, okay, what is this plantar aponeurosis for? So if you want to look the architecture of the foot, you need to think of a suspension bridge. Think of a suspension bridge where you have a dome and where there is a suspension in between. You just imagine, I'll show a picture of it, then you'll understand that. So soft tissue also plays a major role, and that actually keeps the foot in a way that the architecture is maintained so that the arches are maintained. So this is nothing called windlass effect. So I'm not going to the detail of it because it's all a simple physics. And the foot is nothing but a marvel of simple physics to maintain the architecture, something like similar to the bridge. But unfortunately, patients with diabetes will have all the 4 problems in skin, muscle, bones, and nerves, and vascular, every problem. So they end up having the distortion of the bones. So then coming on to the muscle. So you may be wondering why the peroneus longus is this side and peroneus brevis is that side, and why it is actually going through the groove in the talus bones, etc., etc. You may be wondering why. It is actually nothing but a simple bridge mechanism where it actually, if it doesn't go past through that, it is actually collapses. That's it. That's simple, as simple as that. I'm going to keep it very simple. That's all is about. So it's not that you need to understand about every bones, but it is biomechanics is very important to understand what exactly that happens in the foot. So there are some dorsiflexes. Don't worry what is the name of it. It doesn't matter. And there are some plantar flexors which passes also to maintain the arches of the foot. So that's all this is all about the architecture of the tendons. So, and there are smaller muscles. The smaller muscles are something like small ties knit in between the bricks of the bridges. So suppose you think of like a suspension bridge, there are small bricks. So the brick should have some kind of cement together. So these small muscles act like the bridge where there is it all knitted together like a dome. So I'll show a picture of it, then you'll understand what exactly I'm talking about. So all these muscles to maintain the arches of the foot, so that the propulsion, and also when someone walks or maybe even dance or jump, anything, it maintains the architecture. So these are the intrinsic muscles. I'm not going to the deeper connection of it, because each one has a different mechanism to maintain the architecture, but that is beyond the scope of our discussion. But this is to understand the to recollect our anatomy. But I think this slide probably the one of the important slide where you can see the cross section of the transverse arch. You can see that some of the tendons are tied so that it is pulled equally, so that the medial arch and the lateral arch and the longitudinal arch, transverse arch put together, all put together as 3 arches are maintained like a suspension bridge with the dome. So that is why in this all the muscles, if it is moves away from the groove or moves away from the particular joint insertion, or let's say patient is having clawing, then there is some alteration in the insertion, and there is deviation from the normal anatomy, it gets distorted and there is abnormal pressure. So the biomechanics is all about the muscle and its displacement, or the tendon displacement, muscle atrophy, and the innervation having a peripheral neuropathy and the consequences, it ends up having the altered biomechanics. So this is in a simple way to understand about bringing our anatomy into our diabetes forum. So this is to make it little more understandable. Like you look at like a suspension bridge, you have small muscles and the small tarsal bones knitted together with small ligaments, and there are enough number of tendons which pulls up both in the medial aspect and the lateral aspect, so that the arches are maintained. And to maintain the arches, you need to have some bridge, some support in the down as well. So that is where the aponeurosis comes into the picture. So I'm sure everybody is little clear about why these muscles are being kept in such a place that all our normal foot is maintained, is all about this. If there is a little distortion, there will be flat foot. Little distortion, there will be Charcos, maybe changes and subsequent changes, and there is abnormal pressure. So again, same mechanism for the lateral longitudinal arch also. So all this are and simple anatomical understanding about the foot, which is actually important for the biomechanics. So why it is important? Couple of things. We need to maintain the mobility and the stability. That's all. So if we don't have the arches of the foot, there is distorted mobility, distorted stability, and abnormal pressure, and then lead on to the foot ulcer. I'm not going to the examination part, etc., because that's beyond the discussion. So there are several defects, like in terms of diabetes, and I'm putting it an effect as a complication in the skin, where there are changes in the skin which can cause autonomic dysfunctions and reduced perspiration, and then they end up having a dryness of skin, and there is a breach, and then the infection, and then distortion and of the inner muscle. So it is actually a vicious cycle which goes around and end up having a abnormal pressure. Same musculoskeletal innervation problem, peripheral neuropathy, the muscle get atrophied, or even there are studies which have shown that when there is muscle get atrophied, the surrounding fat also get atrophied, so there is abnormal pressure increases in particular area, like in terms of especially in the first, second and third metatarsal heads. That's where the muscle atrophy is associated with a fat atrophy also. So that is why you can see that the ulcers are very high in certain areas, and you see with patients with clawing. I'll just give one example of clawing where how there is abnormal pressure, so that to stimulate you think when you see a patient with foot ulcer. So there are several changes. One of the changes happens is a Charcot's, where there are experts to speak about this, what exactly is all about. And so I'm not going to the vascular, because vascular changes do have an effect in the distortion of the architecture of the foot. And obviously neurology plays a major role, because innervation and the denervation, or maybe the post-amputation alteration in the changes in the innervation, there are several mechanisms behind this. I won't go into the detail of it. So can we examine a little more bit about the whatever we speak? I thought I'll take a few more minutes here on that, because if you look at any books, there is no books which talks clearly about diabetes foot, about which specialty it belongs to. If you look at orthopedics, they have a bit of piece of information, surgery bit of piece of information, endocrinology bit of information. There is no, even if you look at vascular surgery, they talk about vascular. But in terms of the biomechanics and mechanical aspects examination, it's very, very limited. So what is simple is nothing but the examination of the ankle joint, examination of the small joints. That's all is very, very important. But certain things may not be possible, because it's all very minute examination. If you look at adductor hallucis or abductor hallucis, it's become a little more tedious. But if a patient is having a crowding of the toes, or maybe having them overreaching of the toes, which you commonly see in patients with diabetes, you might need to examine. Because why it is important is the next level of therapy is moving towards surgical offloading. So for that it is very, very important, because I wonder how many surgeons in this country will eventually do surgical offloading, but it's becoming a bedside practice in many centers. So that is where the importance of this muscle and biomechanics come into the picture. So these are the common visualization of the changes you can see, like high arch foot, or hammer toe, mallet toe, and bunion. These all are very common. I am not going to explain everything in detail, because this all you would have seen in plenty in your outpatients. Not in patients with diabetes related foot ulcer. It is like any patient who comes and walks into your clinic, you make them lie down. If they are having diabetes for more than 10-15 years, you could actually see all these changes. One of the changes will definitely be there. But some of the examinations, which I borrow the slides from my PMR colleague, because we do work as a team. So these are the slides I borrowed from them, and what I was trying to see what they examine one day, and then I figured out actually examination on foot does not end with inspection, palpation, and percussion type. It's actually much beyond that, where they do a lot of look at the alignment, ask the patient to stand and look from the behind and see whether the calcaneum is aligned to the floor, whether the tibia is and the fibula is aligned to the floor, whether the knee joint is having crepitus or having osteoarthritis, if the hip joint is having osteoarthritis, to see whether, because the changes in the foot can have an effect as high as up to the hip joint or even to the spinal level. So examination is very, very important when there is foot ulcer. But if you ask whether it is really needed for the examination, I am not here to teach for the examination. I am here to teach for the future way we look at patients with diabetes foot. So this is a simple examination. They asked to put the patient, asked to stand a tiptoe and see what is exactly the patient is able to have a motion in terms of the ankle joint, subtalar joint, and look at the way the patient is having varus deformity from looking at from the behind. And I won't go into the detail of all this, because this will be covered in the radiology, I believe, right? And also Charcot. So this all the some of the angles which you could probably measure to look at the arches of the foot, because arches of the foot is very important in terms of the maintaining the pressure distribution across. Second, before finish, I just thought very important is the gait. When you look at the gait of a patient with diabetes, there is definitely changes in the gait. One of the understudied part of diabetes is the gait and its effect on diabetes on gait. And if I walk, you all walk, we have a stance phase and a swing phase. Stance phase is around 60%, swing phase is around 20%, 40%, and stance phase itself has a dorsiflexion, plantar flexion, controlled dorsiflexion, controlled plantar flexion. There are several continuous motion happen in the foot, and it is like our eyes. If one eye adduct, other eye is abduct. So it is like that. So one foot has a tip, other will have a heel. So it's a continuous motion. So always there is a pressure distribution happens to maintain the bridge in the suspension order. So if there is little proprioception or a joint position problem, that's it. There will be an abnormal pressure distribution. This is all about this biomechanics. All right. So there are few studies which talks about what exactly happened in diabetes foot. Is basically patients with diabetes were found to have a slower walking speed, wide base gait, and prolonged double support time. That means they don't actually walk in a support in a way that they would. So what happens is the patient have a lesser sensation in the right foot, suppose, and have an ulcer. They paradoxically put weight on the ulcer area. So that is a problem. So we talk about offloading and to put the other foot. If suppose I have an ulcer in the right side, I don't have a diabetes, what I'll do is I'll obviously will try not to walk with my right foot. But unfortunately, patients with diabetes will have a paradox. They will have more pressure on the ipsilateral ulcer side, and that's why the ulcer. So I'll give a simple example what exactly happens. So if you have a patient with clawed toe, you can see that the green one are the flexor longest tendon, and the other one is the flexor brevis. So you can see that moment there is distortion, there is an abnormal pressure happens in the head and of the first metatarsal, let's say for example, and there will be a abnormal pressure point, and there is also found, the studies have found that there is atrophy of the fat also. So there is much more closer proximity of the bones towards the skin, so there is more ulcer. So that is why the current generation is moving towards a surgical offloading of these small changes. But there are studies have shown that it is good, but our studies are not shown a long-term effect of this is not clear. And if you look at the IWGDF guidelines also, if you look at that in 2023, they advocate surgical offloading for certain maneuvers to a little higher level as high as moderate. It was actually low evidence in the 2019 guidelines, now it is moderate. Probably in the next couple of decades, probably it will have, because there are more studies coming up. So this is again, you can see not only in the plantar, it will have an effect on the dorsi if there is a tight shoes. So very important is that always look for the step, how the patient walks, look for the speed, look for the cadence. Cadence is nothing but how they walk, how many steps they walk, how many steps they walk from here to outside the room. So it's supposed to be at least 80 to 90 steps, or let's say around if they're running. Obviously patient cannot. So this, you can take a snapshot of this. These are the changes happens in patients with diabetes, especially the gait. So it is very, very important, because when it comes to the compensatory effect, what happens is because of these changes, there is compensatory effect and also resulting higher plantar pressure in the foot, resulting onto the ulcer. So thank you so much for missing any, time is up, but I'm done with the presentation as well. If there is any question, you can ask, because
we will take the question.
Question is last.
There
Sorry.
is one session, 20 minutes. We will get the question.
Oh, question is at last. I'm so sorry about it. I'm not aware of this. Thank you so much.
Thank you, Dr. Jeva Singh, for your excellent presentation on anatomy and biomechanics of the foot. With this knowledge, we will now discuss about the assessment of at-risk diabetic foot, and it will be delivered by Dr. Amritava Ghosh. He is the Associate Professor and Faculty in Charge, Department of Endocrinology and Metabolism, All India Institute of Medical Science, Raipur. He has published several articles, both in the national and international journal, also authored book chapter. And over to Dr. Amritava Ghosh.
Thank you, Dr. Arijit, for the kind introduction. I thank you for the invitation to speak on this occasion. I'm going to speak on assessment of at-risk diabetic foot. So Yes, foot ulcers are common complications of diabetes with lifetime risk of 25% and annual risk of 2%. And it is a significant contributor to morbidity, mortality, and economic burden. So it is usually, most commonly, it is a triad of neuropathy, deformity, and trauma which predisposes to an ulcer. And the additional risk factors which also contribute to development of ulceration are presence of a vascular impairment, previous history of amputation or past history of ulceration, presence of any poor glycemic control, cigarette smoking, impaired vision, or presence of chronic kidney disease. So when we examine the foot, we should start with definitely with a detailed history. Then before moving on to the examination, which consists of an examination of inspection, the neurological followed by vascular assessment, and finally the risk classification. So when we go on to history, we should ask about present and past history of any ulceration, any history of amputation, any history of any deformities, cigarette smoking, any vascular intervention, presence of other complications of diabetes like retinopathy, nephropathy, neuropathic symptoms which can be either positive or negative. Positive symptoms include paresthesia, burning, shooting, pain, and apart from that, patient can have any deep-seated pain sensation. Negative sensation include numbness and apparent feeling of a dead feet or feeling like patient is walking on the cotton. Vascular symptoms of claudication, rest pain, and should be inquired into. And while examining the patient, it is always important to ask the patient to remove the footwear and before presenting to you. So before going on to look at the foot per se, we should always, if possible, we should take a look at the footwear or get someone at least to have a look at the footwear. If we should ask the question if the foot is appropriate for, footwear is appropriate for the particular foot in question. So sometimes it gives a clue to the cause of the lesion. Like we can see that inappropriate sandal can lead to a presence of ulceration in between the toes, or presence of a nail which is passing through the sole of the foot and causing irritation of the foot, leading to callus or ulcer formation, and or presence of any foreign objects inside these shoes. So all these things should be looked into. After that, we move on to the examination of the foot, which initially involves an assessment of the dermatologic condition. So the color of the skin, the thickness, whether there is any dryness or cracking which predisposes to ulceration. We should importantly look between the toes for presence of any intertrigo fungal infection. And of course, ulceration, any callus, blister, subcallosal hemorrhage, and any nail changes. So all these things should be looked into. So it is very important to plan how to look at the foot and you incorporate in the routine practice. Because when the patient presents with an ulcer, it is very often we just step and look directly into the ulcer and forget the rest of the foot. While examination of the rest of the foot is of course very important, because even if we manage to heal the ulcer, the patient may come with a recurrence if the root cause is not treated. So we should look for the presence of any deformity like claw toes, which is extension at the metatarsophalangeal joints and flexion at the interphalangeal joints. And presence of any hammer toe or mallet toe. Hammer toe is flexion at the proximal interphalangeal joint, and mallet toe is flexion at the distal interphalangeal joints. And Charcot joint should also be, of course, an important complication of diabetes and often very obvious and usually presents in as midfoot Charcot and presents as a rocker bottom deformity. So additionally, we should look for any muscle wasting, presence as guttering between the metatarsals, And subsequently, after examination of the foot per se, we should move on to the examination of the wound, which includes an inspection followed by a palpation of the wound. And then after that, of course, here again, when the patient presents with a diabetic foot ulcer, we should involve the patient at 3 steps. First, as the patient per se, the examination of the limb, and then finally the examination of the foot. And after the examination of the foot, the examination of the wound per se. So in examination of the patient, we should look for the cognitive function, the vital signs, metabolic and fluid status, which and look for signs of systemic involvement leading because of diabetic foot infection. Of course, inspection and palpation of the wound. The wound should be debrided and subsequently reassessed, and we should look for the clinical signs of infection. So if infection is present, we should classify the severity of the infection. Of course, we will be discussing about the infection in the next presentation. So again, we can, based on the presence of ulceration, we can classify the wound as either neuropathic, neuroischemic, or ischemic. So most of the infections, most of the wounds are neuropathic, while around 30% are neuroischemic, and even lesser percentage are purely ischemic wounds. So these are the features of infection. Of course, we will be discussing this in detail in the next presentation, and subsequently the classification of infection. If infection is present, we should probe the bone to look for any, if the wound is deep enough. So if we are able to reach the bone. So ability to reach the bone with a probe indicates presence of, suspicion of presence of osteomyelitis. So infrared dermal thermometry. So infrared dermal thermometry provides an inexpensive means of measuring the local skin temperatures, and focal or global skin temperature difference between one foot and the other foot can be helpful in either predicting the development of an ulcer, or it can be useful in monitoring of acute sarconeuropathic osteoarthropathy. So in one of our studies, we have also shown the utility of this device in monitoring of the neuropathic diabetic foot ulcers. So we have found that this presence of higher temperatures can even predict that the wound is less likely to heal completely, and presence of interlimb temperature difference even persists after the wound closes. So it takes usually around 1 month more for the temperature differences between the 2 foot to normalize. So it can act as a guide to how long we want to offload the patient as well. And of course, it can, if we follow up the patient with thermometry, we can also predict the development of a recurrent ulceration. So this one device is often called as foot and ankle stethoscope. So if infection is present, we should evaluate it further with investigations. Of course, I will be discussing in details later. So after the examination of the foot inspection and palpation, we should do a neurological assessment. So our intention is to look for loss of protective sensation rather than early neuropathy. So loss of protective sensation, these are the commonly used tests that we do. So presence of at least 2 normal tests with no abnormal tests should be there to say that patient is not having any loss of protective sensation. While if any of the tests, if it is abnormal, we say patient is having loss of protective sensation. So this 10 gram monofilament, so it is a nylon monofilament which is constructed that it buckles after a 10 gram force is applied. So loss of ability to detect the pressure at 1 or more anatomic sites indicates loss of protective sensation. So usually we apply it at the designated sites. In addition to these 4 sites, we also apply it in the midfoot and the heel. And we look for, first we demonstrate the patient in the arm. We have to demonstrate if the patient is able to feel. So in the feet also, patient should be able to distinguish the pressure sensation. So we apply a force till the this monofilament slightly buckles, and we keep it in this position for around 1 second. After which we remove it. So patient has to tell where he is feeling and whether he is feeling the sensation. Then 120 Hertz, 128 Hertz tuning fork, we use it to assess the vibratory sensation, tested over the tip of the great toe. And so if the patient stops feeling this vibration sensation while the examiner is still feeling the vibration sensation, it indicates impaired sensation. Then pinprick sensation, we apply it just proximal to the toe nail in the dorsum of the foot, and so that there is slight buckling. And after that we remove it, and patient should be able to feel the pain sensation. Ankle reflexes mentioned as absent if it is absent even after giving the reinforcement. Then vibration perception threshold. So this is also another commonly applied tests we do. So a VPT of more than 25 volts is regarded as loss of protective sensation. So it is again applied in the great toe. Some guidelines mention that we should apply it on the dorsum of the toe rather than the plantar aspect. And then subsequently we should also assess the vascular supply. So it is impaired vascular supply is present in 1/3 of feet, and it is associated with worse outcomes, increased risk of amputation, and usually if it is present, we should also look for presence of cardiovascular diseases. And this is associated with premature mortality. So it is very important to detect for impaired vascular supply. So we should feel the pulses, the dorsalis pedis and the posterior tibial arteries, and it is characterized either as present or absent. Ankle brachial index. So it should be done in all patients who are more than 50 years of age, and even in younger patients who are having multiple risk factors of vascular diseases. Also, if the patient is having any symptoms or signs of ischemic impaired vascular supply like claudication, rest pain or impaired pulse, then we should also do this ABI. So it is measured at the posterior tibial and the dorsalis pedis and compared with the bilateral arms, and the highest of the foot with the highest of the arms, we take out the ratio, and if the normal values are 0.9 to 1.3, less than 0.3 is considered as presence of obstruction, 0.7 to 0.5 is mild obstruction, 0.4 to 0.7 is moderate, and less than 0.4 is severe obstruction. If it is more than 1.3, it can be because of medial arterial calcification leading to poor compressibility of the vessels. So in this case, we need to do one more test, that is a toe brachial index. Here a cuff is applied at the proximal part of the phalanx, and by photoplethysmography, which is applied to the distal to it, we measure the toe pressure. So again, we take out the ratio with the brachial pressure and calculate the toe brachial index. So normal toe pressure is more than 50 millimeters of mercury, and values less than 30 are usually associated with rest pain, presence of skin lesions, and increased risk of amputation. Toe TBI variously reported as more than 0.5 or more than 0.7 in different studies to be normal. Transcutaneous oximetry is another test which can be helpful in doubtful situations, and here again the results are not affected by the arterial calcification. It is measured at the dorsum of the feet with the patient in supine position. The normal values are 40 to 70 millimeters mercury. TCPO2 less than 40 is associated with failure of wound healing. And again, values less than 30 are associated with rest pain or development of gangrene. Segmental pressures, here pressure cuff of 10 to 12 centimeters are applied at various sites, at the groin, at the above the knee, below the knee, and at the level of the ankle. So pressure index is obtained by dividing the segmental systolic pressure with the brachial pressure. So usually the values are more than 1.0. At the thigh level it is more than 1.3. So the segmental pressure at two adjacent points should not be more than 20 to 30 millimeters difference. So if the gradient is more than 30 millimeters, it indicates a significant stenosis in between these two segments. So when the artery is occluded, the gradient is even more than 40 millimeters of mercury. Then pulse volume recordings, photoplethysmographic recordings of the change in volume that occurs with each pulsation. So normally there is a sharp upstroke followed by and a narrow peak followed by a dicrotic notch. So in arterial insufficiency, initially there is loss of this dicrotic notch followed by decrease in amplitude and flattening of the waveform. So vascular assessment, Doppler. So Doppler scanners use the combination of real-time B-mode ultrasound imaging of the arterial wall together with pulse Doppler imaging and examine the flow patterns in a defined area. So it has a sensitivity of more than 90%. So normally there is a triphasic wave pattern as we see in the first, and the second one is biphasic. So usually it consists of a steep systolic upstroke, a systolic peak followed by a reverse component during early diastole and a pre-systolic zero flow. So triphasic and biphasic are usually considered as normal, while monophasic is considered as impaired circulation. So a clear spectral window under the systolic peak is a normal finding and signals the absence of slow turbulent flow components. So if stenosis is present, this window becomes occluded. The degree of stenosis can be quantified by peak systolic velocity ratio and analyzing the spectral waveforms. So peak systolic velocity ratio is the ratio between the peak flow at the region of stenosis and the minimum flow at the pre-stenotic or the post-stenotic levels. So normally it is less than 2.5. If it is more than 2.5, it indicates a reduction in cross-sectional area of more than 50%, and ratio more than 5.5 indicates a decrease in cross-sectional area of more than 75%. So there are other advanced tests like MR angiography or CT angiography, X-ray angiography, which may be done. So if we are suspecting impaired vascular supply. Finally, after this detailed assessment of the foot, we should do a risk classification. So risk classification helps us to determine how we should manage the patient, whether the patient should be considered for a referral, and how frequently the patient should be followed up. So if there is no loss of protective sensation, no PAD, no deformity, then patient can be followed up once every year. If there is any loss of protective sensation with or without any deformity, the frequency of follow-up should reduce to 3 to 6 months. If there is associated peripheral arterial disease as well, we should do a more frequent follow-up and consider vascular consultation. And of course, the highest risk category is the patient who has developed a previous ulceration or a previous amputation, and these patients' foot should be evaluated once every 1 to 2 months. And of course, all patients, we should give advice for daily foot care. We should ask the patient to examine the foot every evening, and we should ask the patient to avoid hot water when washing the feet. Patient should try to look under the feet. If required, patient should use a mirror. Apply a moisturizer, but avoid between the toes. always you use a footwear, use appropriate size footwear, and look into the footwear before wearing the footwear, and should be worn with socks. So take home message is diabetic foot complications are significant complications, and we should focus on detection of any lesions, detection of any neuropathy, detection of any vascular impairment. After detailed assessment, we should do a risk stratification so that appropriate management can be decided upon. Thank you.
Thank you, Dr. Ghosh, for your excellent presentation. So, in around 40 to 95% of the diabetic foot ulcer are get infected, and the infection in majority of the cases are polymicrobial, and the patient may die out of infection. So it is very important to identify the infection and also to select the proper antibiotics. The next presentation is also will be given by Dr. Ghosh. Dr. Ghosh, please.
Thank you. Thank you for this introduction. So, Dr. Arijit has already given the introduction of the initial slide. So, I'll just skip it. So, I'll just move on to identification of diabetic foot infection. We should keep it in mind that diabetic foot infection is a clinical diagnosis. So, there should be presence of at least two of the followings. So, the usual features of inflammation, that is local swelling or induration, any erythema, local tenderness or pain, or rise in temperature, along with purulent discharge. So, there are certain additional secondary signs of infection like non-purulent secretion, friable or discolored granulation tissue, undermining of the wound edges, and foul odor, which can also be indicators of presence of infection. So, we should always differentiate infection from wound bioburden, that is presence of bacteria but no clinical signs of infection. So, that is why a positive wound culture without clinical signs of infection, we should not classify it as presence of infection and should not consider this for treatment. So, once an infection is diagnosed clinically, we should move on to the workup of the patient. Of course, for classification, we need a complete blood count. Certain biochemical parameters like ESR, CRP, procalcitonin can help us in diagnosing the extent of the inflammation. Of course, microbiological investigation is the most important investigation we should consider in all patients with diabetic foot infection, and of course a radiological assessment. So, this slide indicates the classification of the severity of diabetic foot infection. Of course, there is no clinical signs of symptoms. We classify it as non-infected. If infection is present, if it is limited to 2 centimeters from the wound margin, we classify it as mild infection. Moderate infection is absence of any systemic signs, but presence of infection which extends beyond 2 centimeters or extends deeper tissues, deeper than the subcutaneous tissue. That is involvement of the muscles, tendons, or bones or joints. And if there is presence of any systemic features like 2 or more of temperature, that is less than 36 or more than 38, heart rate more than 90, respiratory rate more than 20, PaCO2 less than 32, or leukocyte count less than 4,000 or more than 12,000, then we classify it as presence of severe infection. And we add an O to the classification if bone infection is also present, that is osteomyelitis. So, microbiological assessment is the most important process of diabetic foot infection management, and it is the only definitive way of determining the causative organism. So, there are various methodologies which can be followed. One is the swab. That is the most commonly people use. Aspiration from any abscess, tissue specimen obtaining by either a curettage or a punch biopsy. So, although few studies have shown that swabs are also equivalent to tissue biopsy, however, most studies have shown that swabs are inferior. So we usually avoid taking swabs. Still, if it is only done, it should be applied after the wound has been cleaned, thoroughly debrided. It is applied, as pressure is applied for 5 seconds, and it is rotated, followed by transport of the swab. Of course, as I told, we should always prefer the other methods like taking a punch biopsy. So 2 millimeter punch is used. It is usually rotated and pushed deep into the ulcer, after which it is removed. And we use a forceps to remove the tissue subsequently. Cuvettes are available, with which we scrape at the base of the ulcer to obtain tissue for culture. And if we are suspecting any deep-seated abscess, before we are referring the patient for abscess drainage, we can consider aspirating the pus with a needle and sending it for culture. And once the specimen is collected, we send for processing within 15 minutes of collection. If we suspect a bone infection, ideally it is recommended to get a bone culture, because often soft tissue culture does not correlate properly with the organism causing the osteomyelitis. So in this bone biopsy, or the usual needles used in bone marrow biopsy, so many of you must have done a bone marrow biopsy during your internship. So it is usually pushed with the trocar. Subsequently, the trocar is removed. Subsequently, the cannula is still pushed more inside by rotating it gently. Subsequently, it is removed, and it comes out with the tissue which is sent for culture. Usually, this small bit of tissue, longitudinal tissue, comes out. So if certain clinical indicators, if these are present, we should suspect a diabetic osteomyelitis. Those are non-healing ulcer, large ulcer more than 2 centimeter, deep ulcers, presence of swollen erythematous deformed toes, often called sausage toes, presence of exposed bone fragment, or drainage of pus from the bone at the time of debridement. So as I discussed in my previous presentation, all diabetic foot wounds should be probed with a blunt steel metal probe. So in this, it is gently passed through the wound, and we try to feel that if we are able to feel the bone. Presence of a hard gritty sensation indicates that we are touching the bone, and it has sensitivity of say 87% or specificity of 83% in detecting an diabetic foot osteomyelitis. Of course, if infection is present, we should subject the foot to an imaging. X-ray should be done, which is the initial investigation. However, it lacks sensitivity. Specificity is higher than the sensitivity, around 70% for diagnosis of osteomyelitis. However, even the sensitivity can be improved if we are suspecting the patient is having an osteomyelitis. However, X-ray is not showing anything. We should always go back and repeat the X-ray after a couple of weeks or after a week. So repeat testing with X-rays can be helpful when we are strongly suspecting osteomyelitis. Of course, MRI is the gold standard, but limited in availability. In our hospital, we find very difficult in getting the dates for the MRI. Sometimes the antibiotic course is completed by the time the date of the MRI arrives. But still, the sensitivity is quite high, 96%, and specificity is 84%. So it is the gold standard, and if we are in doubt, we are not getting anything on the X-ray, we should insist on an MRI. So there are other tests like radio level WBC scans or FDG PET CT, which are also available for detection of infection. So microbiological spectrum, so there is wide bacterial diversity, and it often depends on the location, the geographical distribution, and in developing countries there are predominantly gram-negative organisms, while in developed countries and most of the literature report gram-positive organisms as the most important causative organism of diabetic foot infection, notably Streptococci and Staphylococci. In India, it is most studies have predominantly reported gram-negative organisms like E. coli, followed by Proteus, Klebsiella, and other gram-negative organisms, and followed by gram-positive organisms, including Staphylococcus aureus, Enterococcus. So this is one study we had done while I was doing my DM at IPGMER, and we had found that only 20% of the ulcers had Staph aureus, while about 60% of the ulcers had gram-negative organisms as the causative factor, among which Pseudomonas was most common, around 21%, and Klebsiella, Acinetobacter, E. coli, and Proteus were other organisms. So this is a data which I presented last year in DFSICon. So we had done a study on 21 patients with diabetic foot osteomyelitis. In this, there was an equal distribution of gram-positive and gram-negative organisms. So the gram-positive organisms included Staphylococcus and Enterococcus, E. coli, Morganella, Proteus, Klebsiella. These formed the gram-negative organisms, and together they accounted for around 50%. So we should know something about biofilms. These are aggregates of microorganisms embedded in matrix of extracellular polymeric substance. So this contributes to chronic infection and delays the wound healing, and often persistence of infection. So these are usually polymicrobial with predominance of gram-positive cocci, and others are Corynebacterium and gram-negative rods. So manual debridement and removal of biofilms is essential. So this is an important role of regular debridement of the ulcer of the diabetic foot. Even regular dressing changes helps to remove the biofilms. So recommended methods of debridement are sharp debridement and occasionally, if indicated, surgical debridement. So antibiotic therapy, selection of antibiotics should be based on the pathogens we are suspecting, the antibiotic susceptibility of the pathogens, the severity risk, and the risk of damage to the commensal flora. So if urgent, we should send a culture, but without waiting for the report, we should start an empirical antibiotic therapy, and once the culture report is available, depending on the susceptibility of the organism and the response to the already given treatment, we should decide whether to change it. So it is important to send the culture first before starting the first dose of antibiotic. So selecting an antibiotic, again, it depends on whether the patient is having mild infection or moderate to severe infection. In mild infection, we usually prefer oral antibiotics. So if there is no other complicating factors, first generation cephalosporins have been recommended. Commonly used in our countries are amoxiclav. But one thing we should keep in mind, compared to Western literature, we have predominance of gram-negative organisms. So we should keep that in mind and also consider other agents like quinolones. Ciprofloxacin, levofloxacin are quite effective. Trimethoprim and sulmethoxazole, that is cotrimoxazole, are also very effective. So if there is allergy to the beta-lactams, the other agents that may be considered are clindamycin, levofloxacin, cotrimoxazole, and doxycycline. If we are suspecting MRSA, we should consider linezolid, cotrimoxazole, doxycycline, and quinolones. So if the infection is severe, of course, we should prefer injectable antibiotics, and even in certain cases of moderate infection, injectable antibiotics are often preferred. So if there are no complications, beta-lactams, beta-lactamase combinations should be used, or second or third generation cephalosporins. If there is recent exposure to antibiotics, we should again consider beta-lactam, beta-lactamases with sensitivity to Pseudomonas. Cefodoxime, cefotaxime, ceftriaxone, these can also be used. If the wound is macerated or the patient is having ischemia, we should consider higher antibiotics like again peptides or triclosan clavulanate or even meropenem, imipenem. So this should also be considered. So if there is presence of infection, ischemia, gas formation or necrosis, another thing we can consider is a combination of cephalosporin and an agent which is effective against an anaerobe like clindamycin, metronidazole. So if there are risk of MRSA like patient is having prolonged hospitalization, ICU admission or presence of any intravascular device or presence is having any immunosuppressed condition. So in these conditions we should consider vancomycin or linezolid, and other agents which may be considered are again cotrimoxazole, doxycycline. See, these are also risk factors of resistant gram-negative rods. Here again the agents that will be effective are meropenem, imipenem, quinolones, aminoglycosides, colistin. So selection of antibiotics, we often rely on a combination of antimicrobial agents. So this reduces the resistance and is commonly used in our practice, and combination of agents however should be kept in mind the drug interaction potential. Of course there are limited studies assessing superiority of antibiotic class, one antibiotic class over another. So one study found tigecycline to be better than ertapenem. Another study found ertapenem to be better than piperacillin-tazobactam. So this is one of the studies I was discussing earlier. So these are the combination of agents we commonly used, either combination of beta-lactam with ciprofloxacin, clindamycin with ciprofloxacin, cotrimoxazole with ciprofloxacin. Of course this is a study on diabetic foot osteomyelitis where we commonly use ciprofloxacin because of its high concentration it achieves in the bone. So we demonstrated a remission rate of 81% in patients predominantly treated non-surgically with antibiotics alone. So we can see that 60% of the patients received 2 antibiotic combinations. So even some patients who presented with severe infection and we were suspecting ischemia, we used a third agent for initial 2 weeks, that is clindamycin and metronidazole or metronidazole. So bone penetration is good with fluoroquinolones, linezolid. In cotrimoxazole, the trimethoprim has good penetration into the bone. However, sulfamethoxazole also, although it does not have very good bone penetration, it has a high concentration in the bloodstream, because of which again in the bone minimal inhibitory concentration is achieved. Rifampicin has been used in some of the studies in diabetic foot osteomyelitis, particularly in the first clinical trial on the duration of therapy. Rifampicin was used as a preferred agent and should be considered in refractory cases. Clindamycin, metronidazole also have very good bone penetration, and doxycycline has been reported variably in various studies. Some studies have reported very good bone concentration. The duration of therapy, skin and soft tissue infection without complication should be treated for 1 to 2 weeks. However, if there is association of peripheral arterial disease or other complication factors, 3 to 4 weeks therapy should be given. However, even at the end of 4 weeks, if we are not achieving proper clearance of the infection, we should look for other complicating factors in this patient. So if there is osteomyelitis, current recommendation is that we should use antibiotic for 6 weeks. If the osteomyelitis has been treated with a minor amputation and the margins are positive, we should subsequently continue antibiotic for 3 weeks. However, if the margins are negative and the infected bone is completely removed, we can stop the antibiotics after 2 to 5 days. So diabetic foot osteomyelitis has high rate of relapse, and follow-up and reassessment for at least 6 months should be done. Route of administration, oral and intravenous both have equal efficacy, so oral should be preferred whenever possible. It reduces the cost requirement of hospitalization, the duration of hospitalization, and also the risk associated with intravascular catheters. Of course, the agent chosen should have good bioavailability orally. Severe infection, if present, initially intravenous agent should be preferred, and when indicated, parenteral therapy can be started initially, and after 5 to 7 days, we should consider switching over to an oral agent. And some patients requiring once daily antibiotic, we can consider outpatient-based injectable therapy. Topical antibiotics, although theoretical advantage of high dose at the site of wound and low systemic dosage and low complication systemically, it does not have sufficient data to support its use and is currently not recommended. Surgical intervention should be considered if and urgently if there is severe infection, presence of necrotizing infection, presence of extensive gangrene, deep-seated abscess, suspicion of compartment syndrome, or severe limb ischemia. And optionally, it may be considered even in patients with forefoot osteomyelitis without any of these complicating features. Of course, we should always consider surgical consultation. We should not forget the other components of wound care like regular dressing, regular debridement, offloading of the wound, and adequate glycemic control, and in case of ischemia, consideration of revascularization and optimization of medical therapy. So outcomes, more than 90% of these infection can be treated. More than 80% of the osteomyelitis with heal with surgical intervention, and even as we showed without surgical intervention. However, there is high risk of recurrence of ulcer and infection, and patient should be followed up. So take-home message is diabetic foot infection has high morbidity and mortality and should be early identified and properly treated. An appropriate choice and duration of empirical antibiotics followed by, if required, based on the culture report, modification of therapy. Treatment should be given through ideal route and for ideal duration to achieve the optimal treatment outcome. Thank you. So of course, before ending, I thank my institute and my team for being with me during all these cases. Thank you.
Thank you, Dr. Ghosh, for the back-to-back 2 presentation. I understand this is very difficult. Regarding one point I want to mention, that regarding the probe to bone test, I think its negative predictive value is quite high, around 97%, and the positive predictive value is around 57%. And the result of the test usually depends on the expertise of the examiner. So if it is negative, almost osteomyelitis is ruled out. So thank you for your nice presentation. The next presentation will be delivered by Dr. Rahul Gupta, sir. He will deliver on Charcot-neuroarthropathy, which is very important aspect in a diabetic foot. Over to you, sir.
So, very good afternoon. Now moving from an infectious complication to a great mimicker of infection, that is the Charcot's neuroarthropathy. It's a bit easy but a complex topic. But again, for this time, what I will like you to know, definitely know, is that when do you suspect it, how do you screen for it, how do you confirm it, and a brief overview how you're gonna manage it, or how does a Charcot's is managed out. So can I have my slides please quickly? Yeah. So again, I will be only covering the key concepts and beginning with the definition, when to suspect, differentials, how to screen, what are the imaging modalities that you are going to use, and how do you go about managing it. But these 4 things you definitely must be knowing when you leave this hall, because this is something that we see day in, day out. Charcot's being diagnosed late, being considered as cellulitis, abscess, soft tissue infection, arthropathy, whatever you can think you can have. and lastly few cases. So Charcot's neuropathy is what's called as a non-infectious destruction of a bone and joints, which is associated with neuropathy. It's very unlikely that if a patient does not have loss of protective sensations, you are going to be dealing with a Charcot's foot. It has two phases. First is the active phase, which is classically characterized by inflammation. You will have what is a red, warm, swollen foot, and that is one thing where people misses it with cellulitis, soft tissue infections, deep veins thrombosis, or gouts. And once that active phase resolves out, what we have is a chronic phase, which the signs of inflammations are not going to be there, but you may have concomitant residual deformities. If the fractures are there, they are going to consolidate, and which can be seen on the X-rays. So this is what a simple Charcot's would look like. Here what you can see is a left limb, and the right limb is completely swollen and erythematous. So when do you suspect? In any patients with diabetes, if you are having a swelling of the foot, which is if it usually asymmetricals, having a diurnal fluctuations that it worsens up by evening, and after getting up in the morning it has completely subsided out, not associated with any pain. In the background of LOPS, you should always consider Charcot's. And another thing is that if you're having a fracture, a lower limb fracture in a patient with a long-standing diabetes, they should be considered as neuropathic until and unless it's proven otherwise. The impact being is the degree of the overloading and the type of reconstruction that you are going to be using. Again, if you look at these pictures, it's not difficult to get an idea what are going to be the differential diagnosis. In the acute phase, these are all the mimickers that you can have, the most common one being cellulitis. Next is venous thrombosis, sprains, arthritis, fasciitis, sometimes osteomyelitis. The implications here being is that if the swelling is not subsiding after a single course of antibiotics, think something else. Do not keep on repeating the antibiotics for 4 weeks, 6 weeks, or weeks in fractions without considering the differential of the Charcot's. In the chronic phase, the differentials are predominantly the one which are related to the underlying deformity that has been left by the consolidation of the fractures, the sensory motor neuropathies, or the posterior tibial tendon dysfunctions, or acquired flat foot deformities that can occur in a otherwise healthy individuals. So again, if we know that if a diabetes patient is coming and the foot is swollen, edematous, or red, we need to screen them bedsides. And how do you do that is by measuring the most objective sign of inflammation, that is the temperature. And this temperature can be easily measured by using what we call as infrared temperature monitoring devices. Briefly about this infrared thermography, it is just a measurement of a temperature of the surface of the skins, the radiation that is being emitted by the skins. You have device which can capture it, and it can be used for both preventive, diagnostic, and therapeutic purposes. Here, the basic principle of measuring the temperature is that any observable tissue damage will be preceded by an elevated pressure, which will lead to an increase in temperature. And this difference in temperature is what we want to measure. And these are the two common devices that we use for measuring the skin temperatures: the infrared thermometers, which can come as cheap as 1,000 rupees, and infrared cameras, which can goes into lakhs of rupees. The information they usually for a day-to-day practice is almost similar. These infrared thermometers gives the temperature at a single points, where the camera gives a 2D map or a 2D images, JPG images, along with the thermal scans. So how do you go about using in a clinical practice? If there is an inflamed limbs, you want to know whether the temperature is elevated or not. You always make the patients remove everything over their lower limbs. They should be resting in for almost 15 minutes in a supine position. Just make sure that your ambient temperature is relatively stable, and you try to target a 1 centimeter spot size. The spot size means is that you try to measure the area of around 1 centimeter, depending upon the distance that your device is gonna be from the foot. And this will what give you is a numerical values in either degrees Celsius or Fahrenheit, 27 degrees Celsius on one side, maybe 25 degrees Celsius on the other sides. And this is the devices that we use in our clinic. Again, here the spot size ratio is 1, so we have to hold it. And here is the numerical reading that you will be having. And this is the camera that we use. And this is a picture that it creates out. both the GPG images and the thermal map of the foot. And here you can clearly see that this foot seems to be swollen and inflamed. The temperature is elevated out here. So once you have the readings, a thermal map of the foot, the sites that you have measures, you need to interpret it. Our parameter of interest is the difference in the temperature between corresponding sites. So if, as far as diagnosis is concerned, if your difference is more than 2 degrees Celsius or 4 degrees Fahrenheit, you are likely dealing with an active Charcot's, and definitely this needs to be confirmed with additional imaging. If it is less than 2 degrees Celsius, then Charcot's seems to be unlikely because the telltale sign of inflammation is there. However, this patient still may have a chronic phase of Charcot's if deformity is out there. And here also, if the index of suspicion is high, you go ahead with doing in additional imagings. On follow-up, this infrared thermometry is also used on follow-up. In follow-up, if the temperature is more than 2, again, you are likely dealing with active Charcot's. Continue with your line of management in terms of offloading. And if difference is going less than 2 degrees, that means the Charcot's is transiting from an acute phase to a chronic phase of consolidation. And depending upon the degree of consolidation, you may step down of the degree of loading from a knee high to a ankle high devices. Again, if we are suspecting a Charcot's now, what we need to do is the imagings. And the simple imaging to do are the foot radiographs. Briefly, the things that you see after while ordering a foot radiograph is which area of the foot do you want to see, the forefoot, midfoot, hindfoot, or the ankle, because the views and the projections are going to be different. And I will be leaving this to ma'am to cover it in the later presentations. The next thing is we always prefer a weight-bearing foot radiographs, but again, depending upon the degree of deformity and ulcerations, you may not be able to have a standing radiographs. And again, if your clinical index of suspicion of subluxation, dislocation, or fracture is high, it's better initially not to have a weight-bearing radiographs, to first see the non-weight-bearing and then move to the weight-bearing. And what we commonly follow is a 3 projection rule. That means order 2 views at 90 degree, AP and lateral, and a third is oblique. This gives you an entire idea of the forefoot, midfoot, and the hindfoot. The AP view will show you the forefoot, the oblique view will show you the midfoot, and the lateral view will be showing you the hindfoot. I will be coming to the images later on. So from a radiograph perspective, there is phases through which the Charcot's foot progresses out. So first is the prodromal period, followed by development, then coalescence, and lastly the reconstructions. So in the prodromal period, all you have is an inflammation. Your foot radiographs will be essentially normal. Stage 1, the development is characterized by the 5 Ds: reduced bone densities, debris, distension, disorganization, and dislocations. So again, remember, fractures are a phase of a developmental phase of Charcot's. Then comes the coalescence, where their bones go into sclerosis. And lastly, further reconstruction, where this coalescence is further increased, and what you have is an exuberant ossifications or hypertrophic callus. So just showing you the images one by one. Here you can see this patient again had a suspicion of Charcot's. The foot radiographs were absolutely normal, but since the index of suspicion is high, we went ahead and did an MRI, and what you see is this white hyperintensities on fat suppressed sequences, which goes on to show that you are likely dealing with a stage 0 Charcot's. Ideally, this is the phase where we want to pick them because offloading is going to be very effective. Then this is another radiographs of a developmental phase. What you can see out here is an acute neuropathic fracture involving the metatarsobpharyngeal joints. And also, if you closely look at the midfoot out here, you can see there is some resorptions of the bone where the margins of these cuneiforms are not that clearly distinct, suggesting an active resorption. And again, once this development phase goes into coalescence, what you can see is the calluses, the bony consolidation that is happening in the midfoot areas. Here as well as in the midfoot areas, this is nothing but the distorted midfoot bones with the coalescence going on. And if you are lucky enough, if you have those sequential radiographs, you can see these pictures evolving over time. Here is baseline foot swelling edema within ulcers. Again, the x-rays here not completely normal. You can see the resorptions of the phalanges out here, but again at presentation what you see is how badly it has evolved into a developmental phase. And once you offload them and you try to heal them, what you can see is the consolidation of the fractures as well as of the midfoot areas. That is the radiological classifications of the Charcot's, which also gives you an idea as to the evolution, the phases through which a normal Charcot's foot will be going. But again, another important classification one should always also look for is the anatomical classification. This is based on the joints and the bones that are involved. This is the Sanders-Freiberg's classification. One means the interpharyngeal joints and the metatarsal pharyngeal joints. It is predominantly resorption. So resorption is what we call as candy-like appearances. You can see here that the distal ends of the metatarsals as well as the proximal phalanx here are undergoing resorptions. And once you offload them with good modalities, what you will have is a complete reappearances of the bone which are not visible out here. So this is a bony resorption where the bone collagen in the matrix remains, but the calcific component is gone. The second and third are the intertarsals and the tarsometatarsal type 3. And this is one which is characterized by the subluxation fractures and dislocation. So here you can see this fragment out there, which is nothing but the navicular, which has broken down into the pieces and projecting out here, and a part collapse of the midfoot because this something is flattening out here. Then the tibiotalar and subtalar joints, they are the worst type of Charcot's anatomically to see because they are characterized by severe structural deformity and ankle instability. So the foot, which is supposed to bear the weight, is having a severe restriction out here, and more often than not, these patients go into amputation. And rarely you may have an isolated calcaneal Charcot's. Here you can see it is a through and through neuropathic fracture of the calcaneum without any underlying soft tissue defect, just swelling, and the foot radiographs picked it up as a calcaneal Charcot's. MRI I will be covering, but we should be knowing when we order it. If you are having a normal radiographs, the suspicion is high, go ahead and do an MRI. You do it when you want to see if there is a concomitant osteomyelitis or soft tissue infections. You want to see the disease extent and activities, and sometimes for monitoring healing and progressions. And what all you look for is bone marrow edemas, the bones and the joints involved, the degree of deformities and subluxations. And so coming to the treatment part, again the treatment goal for any diabetic foot ulcer, or as a matter of fact Charcot's, is same. What you want at the end is a plantigrade, stable, infection-free, ulcer-free, chewable foot which is able to maintain the patient's ambulatory function. This is the ultimate goal for any diabetic foot presentations. And treatment strategies are two. Either you can have a conservative approach or a surgical approach. And surgical can be again further divided into a non-reconstructive, where we try to smoothen out the deformities, or do a surgical offloading by doing a muscle tendon resections or the tendon transfers. And reconstructive, which involves long bone fixations, which is done by orthopedics. Again, how do you decide conservative versus surgeries? The factors to consider are the first are the biological, which are the foot-related and the non-foot comorbidities. Foot-related means the degree of instability and deformity we are having. Non-foot means, does the patient have renal dysfunction or not? What is the extent of edema? What is the hypoalbuminemia? Whether the patient's glycemic control is optimal or not. All these things goes into play whether the patient is going to go for surgery or not. And again, since these patients requires offloading for a very prolonged period of time, sometimes as long as 9 months and above, you also need to consider their social support, the affordability, and the disease understandings. If the patient is a daily wage earner, they are sometimes better served with a below-knee amputation with a early prosthesis, rather having a protected 1 year offloading or surgeries, which may not be socially acceptable, the financially acceptable for them. And lastly, the logistics of the expertise and the multidisciplinary team that are required. So this is something again for conservative surgeries that comes into play, is that as you move from forefoot to hindfoot, and from a simple Charcot's without deformity to with deformity in osteomyelitis, the risk of requirement of your surgical needs keeps on increasing. A unstable hindfoot foot with an osteomyelitis is a very high risk of a below knee amputation, whereas a forefoot with just swelling and resorptions of the distal metatarsal is something that can be easily managed with conservatives. So these are the two surgical indications at few surgical indications at baselines and follow-up. Again, unstable deformity is the most common one. Again, this deformity is what causes the threat to the skin integrities. You have a bone protruding out of the skin, so it cannot be accommodated in an offloading devices. The conservative management, where we as an endocrinologist or physicians have a better role, is aimed at immobilizations, non-weight bearings and offloadings. The gold standard for offloading is total contact cast, and it acts by multitudes of ways. But this is what is gold standard, but that is not always possible in each and every patient. What then you can do is a knee-high device which is rendered immovable, and subsequently, even if this is not as possible, what we use is a removable knee-high devices, and there comes in various sizes and manufacturing processes. Again, the decision of the type of offloading device that we're going to use is primarily dependent upon, again, both biological and the patient factors. If the skin condition is good, you can use a non-removable device, but you are having a macerated skin, so no, you are not going to do it. If your edema is too severe and it's fluctuating, again, here also a non-removable device cannot be used. It is better to have initially a removable knee-high devices. The degree of deformity will decide whether a custom-made versus a prefabricated is required. More the deformity custom-made you have, the custom-mades are costlier as compared to prefabricated, and cost, patient preference are again an integral part of the treatments. Again, the duration of offloading is another. Once you have put them on offloading, how do you follow them? For how long they have to be offloaded? We do it till there is subsidence of edema and the resolution of the inflammation as depicted by a temperature difference of less than 2 degrees Celsius on 2 occasions. And also we do interval radiographs to see whether the structure is stable and there is progressive sclerosis and callar formations. And sometimes when we are in a dilemma, we may also go ahead and do a MRI to see the resolution of the bone marrow edema, which should be there if you are going to transit to a weight-bearing stage, and it has to be a gradual closed interval process. You move from a non-removable knee-high device to eventually to shoes over a period of usually 6 months to 12 months, depending upon the patient's characteristics. Briefly to summarize, I will end this presentation with the case that we had managed. So this 20 years old male with 8 years of type 1 diabetes has come with a swelling of right ankle for 6 months. Here you can see there is a swelling as well as a deformity that is present out here. When you do infrared thermometry out here, you can see the temperature difference, which is definitely more than 2 degrees Celsius, suggesting that this patient is having a hindfoot Charcot's. And once the foot radiographs were done, you can clearly see it is a involvement of a midfoot Charcot's with destructions as well as the fractures of the midfoot bones, the cuneiforms, the navicular, partly the talus, and talus is actually dipped down. So our diagnosis was a midfoot Charcot's neuroarthropathies, the Sanders fiber stage being 3 and 4. It was active, Iconol stage 1, and he had a deformity involving the hindfoot. He was offered TCC, refused. We put him in a custom-made bivalve AFO along with a tripod sticks, and he was subsequently followed up. And if you see out here at 6 months, you can see the fragments now, they are getting consolidated. The edema also subsided, and the same thing can be seen on the lateral radiographs where the degree of fragmentation is reducing and the sclerosis is being seen out there. So to conclude, always have a high index of suspicion for Charcot's. Any swollen limb in diabetes, in my opinion, should be considered to be Charcot's until unless proven otherwise. You should use higher thermometry in clinical practice. They are very low cost devices and easy to use. At least get a foot radiographs, hardly cost 50 to 150 rupees, but the amount of information they give is huge. you have to manage them aggressively with offloading in the early phases, and if required, a timely surgical referral. Thank you.
Thank you, Dr. Gupta, for your elaborate presentation. You rightly pointed out that sarco is should be looked upon in every cases, because most of the cases it is underdiagnosed, and in some of the cases patient present in very late with the deformity or disorganized foot. So it is very important to diagnose the sarco early, and for this we need imaging, and this presentation will be given by Dr. Madhvi K. He is the professor and lead of MSK Radiology Sub-Unit CMC Fellow. Ma'am, please.
Thank you very much. Thank you for the kind introduction. And I would also take this opportunity to thank all the organizing team for giving me this opportunity. My talk is on imaging in diabetic foot, the principle and practice. So my talk is made simple by the previous speakers, and most of the concepts are already said in detail. So what I would do is I'll just take you through the radiographs, and the principles and practice of the diabetic imaging in diabetic foot remain same even after a decade. So there's no absolute change. So the principles are to identify in an early stage and characterize whether there is only a soft tissue involvement or is there a bone involvement. And of course to differentiate between osteomyelitis versus a Charcot arthropathy. And to understand, once we identify the abnormality, then we need to understand the plane of involvement and is there any deeper structures involvement. And imaging does help in assessing the treatment response and also healing to the progression over a time period. But what is the practice? So practice is always correlate with the clinical findings. There is no role of imaging without correlating with the clinical findings. And it has to begin with the clinical input and has to end with the clinical input. So to this, a stepwise or a combined imaging strategy based on the clinical query. Of course, to begin, clinical assessment plus a radiographs is the initial assessment, followed by as and when required ultrasound or MR. And Doppler is preferably for the vascular assessment, and CT is for pre-surgical planning and also the post-surgical decisions when there are implants, and to assess the occult fractures. So I would skip the Doppler and the CT component, and I'll focus on the mainstay of imaging, that is the radiograph. And I would focus on the how do we identify in the early stages, how do we interpret the radiographs. And I'll take you through the MR as and when, why MR is indicated, and how the MR images or MR findings will appear. So of course, as we have just heard that before interpreting a radiograph or even looking at the radiograph, we must know where exactly the problem and why are we seeing the radiographs. So what is the indication? So is there an ulcer? And if so, where exactly it is located? Is it infected? Does it probe to bone? And clinical suspicions, is it fracture, or is it an osteomyelitis, or is it a Charcot neuropathy? So here is the first case. So always zoom up once you know where the location of the abnormality clinically is. So for example, if it is in the forefoot, try and look at the forefoot, magnify the images, zoom up the images. So this particular patient had presented with recent worsening of forefoot swelling. So what are we seeing here? So of course there is a swelling of the soft tissue both on the dorsum as well as the plantar forefoot. But there's no definite ulcer clinically except for the foot swelling and increased warmth. So what do we identify on the radiograph? Are these radiographs normal, or is there any abnormality in the radiographs? If we pay close attention to the forefoot bones, there are focal areas of resorption or an osteopenia, particularly at the subarticular locations of the MTP joints. So what we are dealing with, is it an Charcot or is it an early osteomyelitis? So the MR done at a subsequent time, what is shown here is, of course, there is a diffuse edema in the subcutaneous plane. As you can see here, these are the fluid sensitive sequences where the edema will appear brighter. And in addition to that, even the muscle plane has edema. There are no collections. But corresponding to the osteopenia or the resorption seen at the MTP, so there is a subtle bone edema indicating it's an osteitis and no frank destruction. So it's kind of an early Charcot. So this it's bring back to the radiographic assessment that it is essential to identify the subtle changes on the radiographs. So as everyone said that radiographs has low sensitivity and specificity around 55 to 70%, but the sensitivity and specificity can be improved if we interpret the radiographs very systematic way and look at it very carefully. So the sensitivity can be improved. So unfamiliarity to the subtle soft tissue and osseous changes makes it even more unreliable in the earlier stages. So how do we review? The pearl is, first of all, first and foremost, even before you look at the bone, always look at the soft tissue. So what is a soft tissue abnormality we are looking at? If there is clinically a 4-foot ulcer, look carefully at the soft tissue. That gives us a lot of clues. I'll just show you a couple of examples. So soft tissue has to be interpreted all the way around. Then look at the bone. All the bones, carefully follow the cortical margin or the bone margin. Make sure the cortex is uniform and smooth. And there are no areas of cortical break, and there are no areas of bone resorption. That means the bone density has to be maintained. And look at the joint alignment. Is it aligned or the alignment is lost? And always, always mandatory to look at the previous examinations, particularly the previous X-rays. That does help us to identify the any changes or any new findings in the current radiographs. In addition to that, the angles are Meary's angle and the calcaneal pitch angle. Meary's angle is nothing but if you draw a line on the lateral radiograph from along the long axis of the talus and another line along the long axis of the first metatarsal, the angle should be 0 degrees. If it intersects or if the angle is positive, that means the alignment is lost, and it usually seen in the rocker bottom foot. And calcaneal inclination or a calcaneal pitch angle, if you draw a line along the posterior border or the posterior cortex of calcaneum and an absolute horizontal, it should be 18 to 20 degrees. So if any abnormality indicates that, again, medial arch of the foot is lost. So visually we can say, but these angles are more objective way to say the alignment. So here is another example how subtle findings are essential to interpret. If you look at this case, he had a 4-foot ulcer, particular at the great toe. So the 4-foot the AP radiograph, oblique radiograph was taken. So that's a magnified image. What are we seeing in the magnified image? Of course, the soft tissue thickening is confined to the tip of the great toe. In the more oblique view, you can see, if you can appreciate here, so there is a subtle periosteal reaction or the periosteitis that is seen along the medial cortex. So whenever you see a periosteitis, so that's an indication that there is an underlying osteomyelitis. So if you don't pay an attention to this, this is the early changes on the radiograph which one must be careful to identify it. Here is another example, again a great toe ulcer. What are we seeing here? So there is, of course, soft tissue thickening or soft tissue swelling of the great toe. In addition to that, there are motile lucencies within the soft tissue at the first IP joint. In addition to that, the bone resorption is more evident along the subchondral locations of the proximal as well as the distal phalanx. So you can see the subsequent MR where there's definite osteomyelitis confined to the first IP joint, both involving the distal phalanx as well as the proximal phalanx. So it is essential to look at the, wherever there is a soft tissue swelling or soft tissue thickening, look carefully for the adjacent bone, look for whether the cortex is intact are there any focal areas of resorption? So that tells us that we are dealing in osteomyelitis, and further MR is definitely indicated. So here is another example. Of course, this radiograph sensitivity can be improved with serial radiograph. So here is a case with a follow-up case of diabetes with an amputation with recent onset of swelling. What are we seeing? So there is some subtle soft tissue thickening. And this kind of cases has to be imaged at regular intervals. Even infinite X-rays is justified to take in this so that we don't miss the early osteomyelitis. So subsequent radiograph taken after 2 weeks, you can see the spread of soft tissue swelling all the way up to the ankle region. So this is essential to take serial radiographs, and there's also osteomyelitis at the stump. And this was the MR taken to find out whether there is any deeper involvement and whether there are any collections that has to be drained. But there are tiny bits of collections in the dorsum of the soft tissues. Another example how serial radiographs does help to identify and improve the sensitivity of the radiograph. So as you can see here, as compared to the baseline radiograph, there is resorption of the midfoot joint. As compared to the baseline in the follow-up at 3 weeks, the bone resorption is significantly increased. And clinically also, the patient's symptoms are not subsiding despite the conservative management. And subsequent MR shows fluid sensitivity sequences. There is a bone marrow edema, which appears as a hyperintense. A normal marrow on fluid sensitivity should look darker. So anything that is too brighter indicates there's an abnormal signal. And as you look on T1 is the most important sequence. The normal marrow should be brighter, but in the midfoot you can see a low signal within, and the low signal is involving entire bone rather than subchondral location. So that is indicating this case is a Charcot with a superimposed osteomyelitis. So to identify an osteomyelitis and to differentiate between Charcot arthropathy versus an osteomyelitis, T1 is the single best sequence, and the bone marrow or an abnormal signal should be seen not at the subchondral location, but beyond the subchondral location. If you're seeing an abnormal signal beyond the subchondral location, that means it's a case of an osteomyelitis. Of course, collections and draining sinus tracts with more specific feature, and that helps us to easily identify. But it is essential to identify at this stage, and it's essential to differentiate between Charcot arthropathy versus an osteomyelitis. So again, another case where serial radiographs does help to identify how the disease is progressing. So as you can see from compared to the baseline to the 12 weeks, there is slow progression and destruction. So this was again a case of Charcot arthropathy of the ankle. Radiographs does help to identify the progression and the treatment response. As we can see in this case, there is an osteomyelitis of the distal phalanx of great toe where the bone is resorbed, and there's also soft tissue thickening. And this patient was put on the conservative management and offloading. Subsequent radiograph taken at the end of 3 months shows the bone is reforming and there is a sclerosis, suggesting that there is a good improvement. So radiographs does help. The serial radiograph at 3 months and 6 months to understand the improvement is essential. So another case where there is a soft tissue thickening as well as the bone resorption of the midfoot. The question is it a Charcot or is it an osteomyelitis? As we can see on the MR, so there's only a soft tissue edema seen confined to the subcutaneous and the muscle plane, but the bone, there is no abnormal signal within the bone on the fluid sensitive sequences. On T1 again, we are able to see the normal bone marrow. There's no abnormal signal within the T1. So indicating that there is no osteomyelitis, it is just a Charcot osteoarthropathy. The classical case of Charcot arthropathy, where we can see a fragmentation of the midfoot, tarsal bones in this and also a dislocation of the fragmented bone. So that's a classical case. Here's another example of probable Charcot arthropathy, but what we could see on the MR was clinically the patient had increased warmth and swelling. So the question again was, is it an infection or is it a Charcot osteoarthropathy? So as we can see clearly here, so there is a T1 low signal involving the entire bone. So it was Charcot plus superimposed osteomyelitis in this case, but no defined collections to drain it. So one potential pitfall for the interpretation of the radiographs, as we can see in this case, so if we image them when they're already in a bandage or in a cast, it is difficult to interpret the lucencies or to interpret even the resorption. So here we can see the patient has already had one wrap around the forefoot, and that will preclude us from interpreting optimally. So the image has to be taken without the bandage, otherwise the cast will cause a multiple mortal lucency mimicking like a necrotizing osteomyelitis. So that's one potential pitfall to remember, and radiograph has to be taken without the cast, otherwise we may end up overcalling every case as an osteomyelitis. Another potential pitfall for the radiographs, even in multiple radiographs, occult fractures or a significant fracture can be easily missed. So whenever we see that there is probably a potential fracture, in such scenarios, CT is essential to understand the impact of the fracture. So just to quick recap of the radiographs, of course the pearl is to start with the clinical, where exactly the problem is, and then interpret it systematically. Always look at the soft tissues, then bones, all of them, look at the joint alignment. Of course, previous examinations and clinical correlation is mandatory. MR is essentially reserved for osteomyelitis versus Charcot's. But of course, MR, the major limitation is availability. In such cases, ultrasound does help to rule out particularly in initial stages, if there is any osteomyelitis or is it just a soft tissue swelling. We are fortunate to have a good clinical colleagues where the clinical question is very straightforward. In most of our ultrasound requests, we get a query, rule out an infection, rule out a collection. So I'll just take you quickly a couple of slides about ultrasound. So we do it very regularly. So a normal ultrasound will of any, this was at the foot. So what we are seeing is the skin subcutaneous and the muscle plane, and that's on the transverse axis. So as opposed to this, so this was a case of a diabetic, two different patients of diabetic foot with clinically forefoot swelling. So what are we seeing here? The subcutaneous plane is more echogenic as opposed to a normal scan, and this also is increased in thickness. There is multiple layers of fluid that is separating the subcutaneous fat, and that is more severe in the lower case. So this was simply a cellulitis pattern, and there were no discrete collections within. A severe form of cellulitis showing a couple of pockets of ill-defined fluid, but again no definite collections. Underlying bone is completely normal. So a normal bone should be, the cortex will look echogenic and it should be smooth in contour without any cortical break. Another case with clinically an ulcer to rule out an osteomyelitis. So this is again a forefoot ulcer. As we can see the defect in the skin along the plantar part. So that was the ulcer, but deep to the ulcer there is only a granulation tissue but no collections, and it is way away from the bone. So of course there's no osteomyelitis in this case. So another example to rule out an osteomyelitis, as we can see here, the cortex is fragmented and in ill-defined collections at the plantar aspect. So definitely saying it's an osteomyelitis and infection. So ultrasound is a very quick tool, does help to identify whether it is a collection or it is just a cellulitis, or is it confined to the soft tissue, or is there a bone involvement. So it's very useful, particularly if MR is not available. So just to sum up, the principle remains the same, and the practice, one should always know to begin always with the clinical query and end with the clinical query. Then only imaging makes a sense, otherwise it doesn't make a sense. So it has to start with the radiographs, make sure the radiographs are read in a very systematic way and identify the subtle changes. Of course, ultrasound has a major role in diabetic foot. Thank you very much.
Thank you, ma'am, for your very excellent and pointed presentation. Thank you.
Thank you.
So the next presentation will be given by Dr. Rahul Gupta. And now we will look after about the comprehensive wound dressing in diabetic foot.
So before I begin these presentations, I think the important thing to realize is the need of knowing how to dress a wound, because most of these patients are chronic patients with chronic morbidities and chronic wounds. And while you may be able to do a amputation, resolve out the infection, the eventual goal is reepithelialization, and to assist that we require a wound dressing that has to be adding a cost, burden of cost that is there, and we have to do it in the most simplest of the ways, in the most easiest of the way that the patient can do even the dressing at the home as well. So before I begin with the presentation, I will just want to give you a brief overview of the Indian wound dressing markets. It is hundreds of millions of dollars of industries with hundreds of products that are available over the counter for dressings, but very few products have a good quality level for evidence backing them up in terms of time to reepithelialization or time to complete healings. And the best example is the negative pressure wound therapy, which is being used in and out. But a recent RCT published in Lancet 2025 goes on to show that it does not impact the median healing times. Even a previous Cochrane review has shown the same, but we continue to use this. There are limitations to the study, but something we need to ponder. And with this background, I will, rather than being comprehensive, will stick to the principles of the wound dressings, something that anybody and everyone can adopt and practice in their clinical practice. And we'll be covering this topic, defining and ulcers, what are the function of epidermis, what is an ideal wound dressings, how do you dress a wounds, and certain special situations. So ulcer is nothing but a break in the continuity of the epidermis or a part of the dermis. And knowing this, what we want to do is mimic the function of the epidermis. The first most format beings is protection, physical barrier. It acts as a physical barrier to multitude of traumas. It prevents the water loss, keeps the tissue, provide the tissue with an adequate moistures, regulates the temperature, contributes to the excretion of the solutes, and very important role is its sensations that is out there. And when this epidermis is not there, this is something we want to recapitulate or reproduce with our dressings. And this brings us to the what are the ideal features of a wound dressings. It should maintain the moistures without any surrounding skin macerations, should be non-adherent to the wound bed. Means once you remove it, the granulation tissue should not be coming up along with it. It should be very easy and smooth to remove, facilitate the granulation tissues and reepithelialization, act as a barrier to the surrounding bacteria. It is non-toxic and allergenic to the surrounding wound skins. Minimal change. It should last long. It's not like you need to change it every 2 hours. It should be cost effective. This is something very, very important for most of the patients, at least that I see. It should be easy to apply and remove, that the patients himself or the caregivers can do that at home. And the last important thing is that it should have minimal bulk, because eventually this foot has to be put into an offloading device or a shoe. These shoes, if you are going to put a too thick of a bandage, it won't be there, and what you see is the patient walking on the dressing, just saying that yes, they cannot wear the footwear with it. So before moving to the actual act of dressing, just wanted to say this, that these dressing principles will confine to the wounds which are meant to heal by secondary intention, primary closure or delayed primary closures. These higher advances will, the following slides will not apply to the skin grafting, flaps or free tissue transfers, which are usually left best to the specialists that are gonna do it. So coming to the steps of dressings, the first thing is getting yourself prepared. The next is the wound assessment. The third is preparing the wound bed. And lastly, the act of the wound dressings. Getting the prepare involves again 3 things. You set up the room where you're going to dress this. You take care of the equipments and the consumables that are going to be required for the dressings. And the process of it. Now, the wound dressing process may not be completely sterile. What you want is a clean process so that the contamination is not there from one patient to the other. It need not be necessarily sterile because this is a wound which is already colonized with the bacteria. So again, setting the room, this is what we use in our clinic. We have a patient couch, area where the foot is going to be there. We cover it with a drape sheet and a cotton pad, which soaks up all the fluids that are used for washing the wounds and then can be easily wind up and thrown into the appropriate dustbins. If you have the resources, something which is more comfortable and safe for the patient is to have a podiatry chair, which can be easily used out. This is a stool where I sit to do the dressings. Next is the setting up of equipment and consumables. This is our dressing trolley, which is many things compacted into one single structures so that it can be moved around as and when required. The lower layer here contains a whole lot of things, beginning from unsterile cottons to the sterile container and swab sticks, which are required for taking the appropriate tissue samples or pus samples. The syringes used for cleaning, washing the fluid, aspirating the pus, or given locals if it is required. The drape sheets to put beneath the feet, the disposable gowns, the fluid, the normal saline 100 ml bottles are preferred because you can use one bottle for one patient and then discard it, again decreasing the risk of cross infections. The gloves and the roller bandage. And the top layer again here constitutes a lot of things, the dressing materials, the wound cleaning solutions, the instrument trays. I will be just discussing in brief the few of them because just to give an idea that how do you go about preparing yourself. Everybody can individualize depending upon the resources that they have. So these are the few basic instruments that one should always have before doing a wound dressings: a bandage cutting scissor, a surgical curette, a blade handle, and a tissue cutting scissors to prepare the wound beds. Again, the forceps to pick the gauze pieces or to manipulate the tissue arounds. These are the common primary dressing materials that we use: the gels, the iodinated ointments, the tube ointments for chemical debridements, the paraffin gauzes, sometimes the collagen granules, and the materials that we use for secondary dressings, which I will be coming, what are primary and secondary dressings. Again, remember the sizes of the dressings that are going to be used out here. Since you are dressing the foot, which is consisting of the digits, the size of these roller bandage should ideally be between 2 inches to 4 inches, which is between 5 to 9 centimeters. You may use shorter than that, but longer bandages just adds to the bulk of the wound dressings and does not helps. So next step, once you are prepared yourself and the patient is appropriately positioned, comes the act of wound assessment. And the 9 things, these are the 9 things you should always be thinking again and systematically addressing out, beginning from the location, size, whether it is a surface wound, the degree of exudate, necrotic debris, edema, vascularity, surrounding skins, and the eventual offloading strategy that you are having. As an example, I will be just following this wound and how do you go dressing this wound. A very simple wound at the base of the at the base of the metatarsus. So just see again the 9 questions. The location, it is 4 foot. And next the implication being is that the dressing the digital area is a bit challenging, unlike other surgical wounds that we have. The size and depth of the wound helps you go on deciding the size of the dressing that you are going to use. Surface wound or a cavity wound, this is a service wound, and the distinction between two, I will be coming that what are the intricacies of dressing a cavity wounds. The degree of exudate is very important to assess any wound because you want to have a moisture balance. It should not be too much that it macerates the skins and does not allow reepithelialization, but it should not be too less that it does not allow the wound. cause the wounds to dry up and again inhibits the epithelializations. Here the amount of necrotic debris is nil, almost minimal. Again, if it is there, I would go on deciding the need of debridement. The edema. So in patients with diabetes, what you have is that they have a long-standing neuropathy along with an edema, and you have to decide whether a compression bandage would be required to allow an early healing. The vascularity again is required for degree of compression that you can give around the bandage. The surrounding skin here is healthy. You do not want the exudate to pile up within the wound to cause the skin macerations. And offloading, which goes on to tell you the degree of the bulk of dressing that you can put over the foot. So once you have assessed these 9 things in the wound, comes preparing the wound bed for the dressings. First is you clean all the exudate using a clinical cleaning fluids. Cleaning fluids I will be discussing. Then you remove the necrotic debris, whatever methods you want to use, mechanical, chemical, autolytic, enzymatic. And the third most important thing is removing the biofilms if they are present. They have to be mechanically removed most of the times. Briefly about the clinical cleaning fluid, the fluid that you are going to use to clean the wound bed, the preferred is a sterile distilled water or a 0.9% normal saline because they are non-toxigenic to the underlying granulation tissues. However, in selected situations where you have too much of necrotic debris, ongoing infections, or extensive biofilms, you may use these povidone, iodine, peroxide, usols, or Dakin solutions to just clean up that surface to have a red, healthy granulation tissue beneath it. So here, if you see in this wound, I will be preferring a normal saline or a distilled waters. But if you come to this wound which is having an extensive necrotic debris out here, even post debridements, this is something we use povidone, iodine or hydrogen peroxide may be utilized to clean up these necrotic debris. Again, not to address the granulation tissue, but to remove the necrotic debris. Coming back to our wound again, which is preparing the wound beds. Cleaning fluid again, a simple normal salines. There is no necrotic debris out here, so no debridement is required. But yes, you can see here there is a slimy mucus-like layer, which is nothing but the biofilm, and it has to be mechanically removed using a curette. So this is using a curette, this is taken care of, and you can see the immediate differences between the pre-biofilm and the post-biofilm removal. That here what you have is a red, healthy granulation tissues, and this exercise needs to be done every time if there is an ongoing biofilms. Another example of a wound, again clearly a severely infected wound. Here we clean it with iodine and a normal salines. There is a too much of necrotic debris, and what is required is a sharp debridement plus minus and amputations. In an active infective, a biofilm does not come up, and this is what it looks like when this post amputations and removal of all the necrotic tissues, something which is now ready for a dressings. Coming last to the, once you have prepared the wound bed, comes the act of the wound dressings. Before I move on to the wound dressings, one need to understand the difference between the primary dressing and a secondary dressing. Primary dressing is something which comes in direct contact with the wound bed. Secondary is something that you use to secure the primary dressing in place. So the functions of a primary and a secondary dressings are distinct. For primary, it is primarily to have a moist healing environment. If it is exudate, absorb it. If it is dry, give moisture to it. It should protect from infection and traumas and deliver any active agents if you are using along with the dressing material. The prime function of a secondary dressing is to secure primary dressing in place. However, it may also add to the mechanical protection and cushioning, as well as an additional absorption of the exudate, where the primary absorb it, the secondary further takes it away from the wound surface. The examples of primary dressings and secondary dressings, the gels, alginates, colloids, paraffin gauzes, collagen granules are primary. The sterile gauzes, the roller bandages, the crepe bandages, the dynaplast, what constitutes your secondary dressing. Even if you are stapling a wound film to a wound bed is what constitute as a secondary dressings. Any dressing, the most important thing is we want to maintain a moist environments, and based on that, dressings can be basically dichotomized as to moisture absorbing and moisture donating. You use moisture absorbing in exudative wounds and donating where there is no to minimal exudates. And again, these are the example of the moisture absorbing dressing. The most common that one we use is a cotton gauze pieces. That is very easy, cheap, and easily available. And the common one which you use to donate moisture is the hydrogels and the paraffin gauzes. Again, this list is not inclusive. This is something that we use oftenly because of their low cost. So this is just an example where you are going to use absorbent dressing and where you are going to give a moisture donating dressing. In a same patient here where you can see the degree of exudate is too much, use here a moisture absorbing dressing, and as and when it is uninfected with minimal exudate, you shift to a moisture donating dressings. Another example here where there is too much of debris, the cavity is too big and the exudates are substantial, you use a moisture absorbing dressings, and eventually you convert. Once it's re-epithelializing, the cavity is filled up, you go on to a moisture donating dressings. Another example, a moisture absorbing infected cavity, visible necrotic tendons, a moisture donating where the wound is now healthy and granulating. So coming back to our case, what we have is an infected wound with no to minimal discharge. We have cleaned it out, and here, since there is no infection, no exudate, we want to give a moisture donating dressings. And if you see out here, we have just put a layer of a amorphous colloid hydrogel, which is not only going to retain the moisture, but also donate it partly. Once this primary dressing has been done, comes the act of secondary dressing. Now I need to secure this colloid gel in place. To do that, I just put in a gauze piece and put it sort of a dynaplast over it to hold it in place. Just see the bulk that has been kept very minimal out here, which is compatible to accommodate in the offloading shoes that was provided to this patients. You don't want to wrap it in long gamzy rolls, which will not be accommodated in these footwears. Minimal, the bulk, keep it minimal as much as possible. Now, this brings to me certain special situations, the intricacies of how do you go about dressing the digits of the foot. The challenges here is they are cylindrical shaped with curved surfaces, very small sizes, and multiple joints. All these things makes holding the dressing over the digits very difficult. They're gonna move, it's gonna come off. Second, the important thing is the risk of interdigital macerations. So again, if you wind up all the digits in a single roller bandage, the fluids is gonna keep in here in between the spaces, and what you will have is a skin macerations. And lastly, one should always remember that digits have an end arterial supply. If your dressing is too tight, if you keep it too tight at the base to hold it in place, what you may end up is with a necrotic tissue. So for secondary dressing in a digital wounds, we try to use very small 1 to 2 centimeter gauze pieces with 1 to 2 inches roller bandage. This is how we go about dressing this wound. If you want to use a roller bandages, just starting from here, we wrap it around the midfoot areas to provide a hold to the dressing. The dressing holds by midfoot, not by the digit, causing no compression at the base. Once these 2-3 layers have been put in, what we do is we move up, we encircle the digits and come back again having a 2-3 wrappings in the midfoot areas. And this can, while here this patient has this you can do is for second digit, third, fourth, fifth, any digits can again be wrapped around like this. And eventually you secure it with a surgical tape. So this is how you go about dressing a digits. Another important thing to realize in these diabetic foot ulcer is to have an assessment whether they are surface wound or cavity wounds. Now the distinction between is the mouth and the base of the ulcers. In the cavity wound, what you have is the mouth is very, very narrow and the base is wide, whereas in the surface wound, the base is wide, but mouth is much wider. What you eventually want is that healing should happen from base to the top, from base to the mouth. But if these cavity wounds are not properly dressed, what you will have is a premature re-epithelialization of the mouth, and it will cause secretions to pool within these cavities, which will tunnel down in the surrounding tissues, will get secondarily infected, creating a whole lot of problems. And the best way to deal them is pack the cavity before you close the mouth of the wounds. So just to give you an example, while this wounds looks good, I can tell you here, from here there was a discharge coming out, and when you probe it with a metallic probe, what you find is a entire cavity which is out there, which is nothing but a post amputation along the flexor tendons. The infection has seeped out here and the fluid is now collecting out here, and it is a big challenge. And to address this, we just simply pack it with the gauze pieces, even thinner ones also comes up, and then close it. The another third important situation is the degree of edema, which is always challenging even with an uninfected wound in the setting of diabetes, and edema's impaired wound healing. We all know this, and the reasons are multitude of them. Here you can see a edematous foot and a non-edematous foot. And if you feel that edema is impairing with the wound healing, what we need to do is what we call as compression bandage. The precondition for doing any compression bandages, there should be no peripheral arterial disease, because if the arterial supply is compromised, you compress it, you are gonna be putting a ischemia. The infection should be under control, and there should be no to minimal discharge. And just remember this Laplace loss for compression bandage. More tightly you pull, higher the pressure. In a same limb, that if you use the same dressing in the digits versus in your tibial area, the compression of the digits is gonna be much more. More the number of layers, more is gonna be the pressure. The narrow the bandage is gonna be, again, the more the pressure you are dealing with. So just to see how they do a compression bandage, this is nothing but a secondary dressing that has been put in over the place of a calcaneal ulcer that was healing and uninfected. The first thing is you prepare the digits. You don't want a compression at the levels of the base of the digits, because it will constrict like this and then may cause the digits to get edematous. Just you put the gauze pieces around these interdigital spaces and secure it with a surgical drapes, and then you continue to apply the compression layers. The preferable width of this compression layer should be around 2.5 to 5 centimeter, and in a circle by circle you wrap it up till the tibial plateaus. Always remember, we try to overlap these layers. If you want to increase the pressure, decrease the degree of overlap, and increase the overlap if you want to increase the compression from 50% to 70%, and other way around if you want to decrease the temperatures. So to conclude, again, wound dressing is a systematic process which is aimed at healing the wounds. It integrates assessment, selection, the function of the limb, and an ongoing review. This needs to be revisited every times, and there is no single dressing which fits all wounds. You have to individualize it. And before I conclude, I will just like to thank my seniors and my colleagues with whom I am being able to manage these foot patients, and who have taught me how to go about dressing the multiple wounds. Thank you.
Thank you, Dr. Gupta, for a very nice presentation. Thank you very much. So our next presentation will be on footwear and offloading in diabetic foot care by Professor Felix. And Professor Felix.
Welcome back and good afternoon again. And so I quickly jump onto the topic per se. If you look at the offloading, which we are using for any diabetes foot related ulcers, you can see one gentleman who comes out always in our textbook is actually the Paul Brand. Paul Brand works in Christian Medical College well over almost 70 years back, and whatever we are using for most of the diabetes foot ulcers is actually been borrowed from Hansen's disease. And whether we like it or not, all are entirely all the products are from that era alone. And he, Paul Brand per se, has actually done quite a lot of work on diabetes foot itself. And sorry for there is an incompatibility between the letters and what I type. So if you look at what exactly is a diabetes related foot disease, it's actually not only foot ulcers, it actually a whole spectrum of disease, starting from peripheral neuropathy, peripheral artery disease, ulcers, and subsequently post amputations as well. So it's a broad spectrum of disease. So if someone talks about diabetes foot disease, it includes diabetes foot ulcer. It's not actually a diabetic foot ulcer alone. So it's even in the IWGDF criteria, it's very clear, guidelines, it's clearly mentioned that it's actually a whole spectrum of disease. And if you look at the first spectrum is pre-ulcerative state, which is actually the one of the commonest, most commonly missed out diabetes foot disease in a patient with diabetes. Because if you see a patient with diabetes comes to you, we always look at the patients with a foot ulcer with a more focus and miss out on the non-foot ulcer foot, which is a contralateral foot. If you look at carefully here, you could be seeing dryness of skin, or could be a fissure, callosity. So excitingly, you might see much more what we probably a reason for a future foot ulcer. And I'm so sorry, there is greater incompatibility and all my slides are so if you look at carefully, you can see this all could be the infections, but it is not patients with diabetes foot ulcer. It is all taken from a patient who has actually visited the clinic for diabetes per se. So you can see all these are, none of them actually reported to have a foot ulcer. So the question is, how do you offload this? That's very important, because we see now outpatients, what do we do about this? So you may see something of this where you probably are bold enough to remove the callosity, and you could see all these changes, and you can see one of this, if someone says a fissures or maybe having a dry skin, you have to really focus on that with moisturizer, or you might need to remove with your simple blades, which Rahul already clearly shown how you need to set up a diabetes foot clinic. You end up using antifungal for nails, and eventually the customized footwear comes into the picture. Because if you don't look at all the other aspects, suppose you're prescribing a customized footwear on a patient which is actually having a dry skin, what you end up is having actually the shear force onto the skin and having a foot ulcer in the dorsal aspect also. So we have as a team, we've taken care with a different multidisciplinary team. We usually prescribe footwear bedside. I mean, bedside means our orthotic person stands near a physician and actually prescribe the footwear, measures immediately and adjusts it immediately. Once the footwear comes back, it is adjusted by a physician also. So even when, if you are looking at a footwear, you can actually look at and see whether how much the footwear is actually worn out. If you, I'm not going to the detail of it, but you could probably take a snapshot of it and go back and look at carefully in your, because in the era of plantar pressure sensor devices of this century, it is impossible to have a sensor all across. We do have sensor, but we don't use it very frequently across, because we don't have a crosstalk between our 3D printers and the footwear pressure. So, but you could actually use a footwear to look at where exactly the pronation, supination is also. That will give an idea what exactly the footwear is worn out, because that is very, very important also. So suppose the patient is coming with a foot disease, especially pre-ulcer state. If you look at any of the pre-ulcer state, whether clawing or mallet toe or hammer toe, which all will be in the forefoot alone. It's not in the hind foot, because if it is in the midfoot, it's go to a Charcot's. And forefoot includes probably the first stage of Charcot, and also the other important smaller joints deformity. It's in the forefoot. So a simple anterior rocker. If you look at any of your footwears, especially the gentlemen who are using shoes, you can see there is a rocker will be there, because our forefoot has a maximum pressure. So that forefoot rocker is exaggerated to a little bit around 8 to 15 degree, and it can be individually depend upon the BMI, depend upon the patient's walking cadence and patient's gait. You can actually individualize, and if there is a subsequent recurrent callosity in the tip of the toes or the digits, or in the recurrent ulcerations despite of using that, then you should go for a surgical offloading, which is actually an upcoming feature for even for pre-ulcerative states without an ulcer. So these are the various gadgets, actually it's freely available. If you look at any online marketing system, you can, if you Google the, I mean, if you put this toe caps or bunion cap or separate, you could easily procure it in your places where if it is, some of the patient may require. And important is this, these patients, if you are prescribing this gadgets, it is important to educate them to wear a sock, because most of our patients may not have the habit of using a sock. So you have to teach them to use a sock. That's moving away from the pre-ulcerative state. That means the ulcer has not happened, but you should definitely offload it. Very important, because as a physician endocrinologist, we should actually look at every patient's feet in our outpatient, especially in patients with diabetes, long-standing. You should look for this feature and have to treat. Second is, when the patient having a foot ulcer, that becomes far more important to have an offloading. Offloading is nothing but if someone is listening offloading for the first time, that means what exactly is offloading is, if I have a ulcer in my forearm, I'm not going to keep it here. I'm going to keep away from this podium and going to keep my hand like this. This is called offloading from the area. So that is called offloading. So when it comes to the management of diabetes, actually speaking, there are 4 pillars. One is, other aspects have been dealt in greater detail. Couple of things is offloading and gait training and physiotherapy, because if you are asking a patient to wear any of this footwear, without a physiotherapy or a gait training, the footwear is not going to serve the purpose. It is like if I don't know how to drive a car, if you ask me to, if I give me a car and say you drive the car, I'm not going to drive it, because I don't know how to use, because we all been living with the stance and the straight gait continuously all through our life, and asking to give a footwear where couple of the phases of walking stance is actually limited, because if the forefoot is off the ground maximum, that means they don't have a toe position on and off. So that is why it is very important to have the gait training, because all this why are we doing is to heal the foot ulcer as well as prevent an amputation, either ipsilateral or contralateral. So what are the various offloading manuals available, as well as been given from the textbook aspect and also the evidence I'm going to talk about in that angle. So if you look at the textbook, it's very clearly all this has been time tested for Hansen's disease as well as for the diabetes foot, especially for the forefoot ulcers, especially anterior rocker or anterior ortho-wedge or metatarsal bar. If you ask me what is metatarsal bar, there are several studies which talks about metatarsal bar in sports maneuver or sports related activities. So we are actually borrowing those biomechanics into diabetes to use it in a better way, so that the forefoot is offloaded when there is forefoot ulcers. And secondly, the midfoot arthrosis, it's a little difficult to manufacture, because midfoot arthrosis needs an expertise of an orthotics. Unfortunately, in Indian scenario, the prosthetic centers are plenty. Like you go for an below knee, some patient are below knee amputation, you will get a prosthesis very easily. But if you go for an orthosis, it is a challenge, because that needs little more expertise and needs more support from the mission-based support. Equipment may be lacking. If it is a hindfoot wedge or hindfoot orthosis, and if you want to completely offload, suppose I have a foot ulcer in my left foot, I have to hop. So, but it is not possible. So that is how the complete offload. As already mentioned, it is total contact cause or air cast boat. Air cast boat is very freely, easily available, which can be rendered irremovable. That means you can call it ITCC or irremovable TCC or instant TCC. You could call in other words also. So those are a complete offloading, but there are other maneuvers like wheelchairs, crutches, all also provides an equal about the complete offloading. So there are two offloading, one is partial and other is complete offloading. So these are the two offloading you could use. But now coming on to the evidence base, what exactly the guidelines talks about. Suppose if you read the IWGDF guideline, this talks, I'm just verbatim cut and pasted those words from the IWGDF. They talk in 3 choices. In 2019, they talk about 4 choices. But now they brought into 2 choices depending upon the evidence. So any patient, whether it is forefoot ulcer, midfoot ulcer or hindfoot ulcer, you should give total contact cause. It has been discussed in greater detail. I am not going to the detail of it. And suppose if the patient is not able to have a total contact cause, what you can use is a ITCC. It is nothing but an instant TCC or irremovable TCC by using a air cast boot and have it cast on the mid calf so that it become irremovable. So that is how actually been tested in the Western countries. So it is called ITCC, but there are certain textbooks write as irremovable TCC, instant TCC, which are alternatively used. But remember, most of the patients do not accept for this total contact cause. So that is why the second one, which is the removable knee-high offloading device, which is nothing but that total contact cause came into the picture. That is one. Or AFOs, that is the second one, which is nothing but which Rahul has showed already. And this is the old air cast boot, and this is again Crow, Charcot restrained orthotic walker. And this is the air cast boot, which comes in a different modalities where you can have a knee-high air cast boot or up to mid-calf of ankle. You can have mid part of the leg air cast boot. You can have a different air cast boot. But remember, air cast boot does not come in the right or left side. It actually comes in a uniform size. Uniform size, and the sides are not matter. You can actually use it either left or right, and you can even reuse this because this all sometimes washable, and in the inner part is actually a cushion. And this is AFO, which has already been discussed. So there are several studies which actually talks about this second evidence, which patient accepts much more faster than the cast, which is very difficult for the acceptance rate. So that is why, I mean, I'm not going to the detail, but this is to show evidence that this ortho wedges is nothing but a customized anterior footwears where you can use it as a second best in as per the IWGDF guideline, but the name varies. If you look at the Western textbook, it talks about half shoes. Half shoes are nothing but wedges, and cast shoes are nothing but surgical shoes. So it doesn't matter because the name alone changes, not the outcome. So these are different shoes which are used in the Western market, and these have been time tested. And it is not that this all have no evidence. This all have enough evidence to show that this works, but the name goes in a different sense, but it's eventually all are wedges. So they have a good transfer of offloading efficacy, and it found to be extremely useful. And even the only problem is patients perceive and having a visual analog. Patient use this and say that they don't feel like using is actually high with this, but otherwise they have an equal distribution. So that is why we actually modified and have an anterior rocker for smaller foot ulcers where you have a higher degree of rocker more than the normal rocker, which is around 2 to 5 degree, and where the pivot starts from 65 degree. And the wedges actually a little more have a more ledge type where you can see the pivot started from around 55 degree. And remember that this all need physiotherapy because otherwise patient tip and fall down. Most of the patient do have a motor neuropathy. So always should have a heel counter, and sometimes we will have another strap in the above the ankle also to hold on. And here you can see also there is, you can see that metatarsal bar, which is actually very easy to fix it. It's a simple piece of rubber, and where there is reservoir setting, you could actually use the rubber and use it. And this actually serves a good offloading like anterior rocker, though we are right now conducting a study to look at how efficiency is that. But remember that what from a clinical experience we can say that this also do works in a research power setting, because we do have a peripheral centers where we have difficulty in manufacturing, we do use this. And second very important is where we really don't take care of some of the foot ulcers is actually the post-amputation foot ulcers. Remember, the post-amputation foot ulcers are very neglected here, and we need to take care of this very efficiently. And the best maneuver would be a post-op walker followed by a customized footwear with a metatarsal bar in the half shoes. That means immediately post-op there will be edema, so you need to have a strap which is much longer, and as the edema subsides, the strap has to be modified. So it is nothing but a dynamic prescription which comes into the play, and it reduces the healing time much faster than just leaving off by almost literally 50%, right? If the patient's healing of that stump is 6 months, if you take care of that appropriately with a walker, and it is nothing but removing my hand from here and keeping my ulcer safe for the next 20 minutes, it heals faster. This simple logic. And we do have a technology to have a 3D printing carved where you can fill it and make the patient much happier. And so this is, can see that simple anterior rocker will suffice this. And if the patient is having motor neuropathy, have one more strap over it. And suppose the patient has an amputation, you put a filler and have a anterior gauge and cover over that so that the patient feels comfortable. And suppose the midfoot, you have midfoot orthosis, difficult to manufacture, extremely difficult. Even in our center, we takes at least 4-5 days to carve. Hindfoot ulcer, osteomyelitis, treat the osteomyelitis with the requirement, and posterior wedge. So this is simple. There is a third choice which is called felted foam. And for the exam goers, if you ask what are the felted foams, is basically the one area alone, they will scoop it out and keep the felt foam. But this is not currently practiced in India commonly. But if you have a resource poor, you could see there are few techniques which has been shown to be useful, but not reduces the healing time much greater. It is nothing but these all three technique is nothing but roll the gauze or roll the glove and keep it around the foot ulcer so that the foot ulcer is little away from the inner sole and have a secondary dressing. So this is all based on felted foam, but it was not a greater dressing and greater offloading device similar to the anterior rocker. Probably this slide makes little more important because this comprehensively talks about all the foot ulcer and how you could probably offload it. Anterior forefoot, anterior wedge or anterior rocker, midfoot orthosis or PTB orthosis, which is difficult to manufacture in any setup, hindfoot rocker or posterior wedge, dorsal foot ulcer, very important because when there is a dorsum, you can't use a strap. You have to actually use a strap which is continuous and close all through and through, so that the friction is uniform and not heterogeneous in one place. So it is very, very important that again it comes in the, and post amputation need to take care of it very simply, and also gait training, that is very, very important. That has been missed out in most of the centers. And if you look at really carefully, the offloading is not 1+1. Suppose you have an 82-year-old gentleman come to you with Charcot, just use the restroom for his daily living and doesn't move out of the room. You could actually use simple footwear because you are just going to prevent a foot ulcer. Suppose you have a 30-year-old gentleman with Charcot, actively walking around, has a healthy lifestyle, want to walk around, you could use a simple air cast boot because he may be affordable, make the ankle joint stable, and then go for a surgical offloading, surgeries, etc., etc. So it is not it is not a fixed offloading maneuvers you could use. You should actually look for every aspect of a patient to individualize, because one shoe does not fit all. So that's the bottom of the line. So I thank my team. It's a big team, and Dr. Madhavi is also here, and this is our big team. There are several team members which are behind the scene helps, and thank you so much for patient listening. Thank you.
Thank you, Professor Java Singh, for your excellent presentation. Rightly, you have pointed out the footwear, and I think the adherence of the footwear is also important.
Yes, I didn't touch that part. Adherence is very, very important. So what we do in our center is every visit we reinforce. reinforce, and that is why we look at the footwear and see where there is worn out, and take a photograph, ask them, last time the photograph is that you looks like you're not worn out. So that's reinforcement increase our adherence from somewhere around 20-30% to 60%. Still, the cultural taboo not to wear footwear within the house. So we advise them to use temple socks within the house and footwear outside the house. So
as it has been shown that in some patient with high risk foot, even going to the washroom without any footwear may lead to the development of ulcer. Thank you, sir. Thank you for your presentation. So,
no, I don't have a control over it. Probably they should that QR code is.
You will do that later. Then our next presentation will be by Dr. Priyander Singh Thakun from AIMS Bilaspur. He is the Associate Professor in the Department of Endocrinology and Metabolism. He has published several articles both in the national and international journal. His topic will be the surgical intervention, when and what to do.
So very good evening to all. So a disclaimer, I am an endocrinologist, not a surgeon. So I'll just be giving an overview from an endocrinological perspective, that what we should know, so that we can request our surgeon just to what can all be done. So yeah, so sorry for this little delay. So I'll just start with my presentation. So as my co-speakers have rightly mentioned, that diabetic foot is not one specialty domain, so it is a multi-specialty work. And we, in that team, a surgeon, a dedicated surgeon plays a very good role. In most of our centers, what we lack is a good surgeon, good dedicated surgeon. In most of the centers, surgery for diabetic foot is usually taken care by the junior most fellow. That is mostly by the first year resident only. So as we tell in our stroke or acute myocardial infarction patients that time is brain, time is muscle, like that, here also time is tissue. So appropriate and timely intervention from a surgical perspective also helps prevent a major amputation, differentiate major amputation from a minor amputation. So what is goal after a good surgical intervention? So one is, now our approach has shifted from a more radical approach to a more conservative approach. So amputation should be, if at all required, we should be doing minor amputation, but not at the cost of the life of the patient. And second is to retain a functional foot. As Rahul has previously pointed, the functional plantigrade foot, that is all the aim at the end of all these things. And that should not only support the mobility, but also allow seamless adaptation to later on prosthesis. So that is the ultimate goal we should keep in our mind. So when to call a surgeon? So surgeon can be called in emergency or urgent situations, like a patient who is having a necrotizing soft tissue infection of foot, wet gangrene, and he is having sepsis, accompanied sepsis or severe sepsis, or there is a localized foot abscess, infected non-healing ulcer which needs serial sharp debridements, or sometimes electively also, like Felix sir has touched previously a little bit about surgical offloading or deformity correction. If offloading, other offloading like offloading footwear doesn't help, in those cases surgical offloading can be tried. And in reconstructive surgeries, especially in chronic Charcot, which Rahul has also touched. And lastly, but not the least, the serial sharp debridement to reduce the, debride the devitalized tissue. So coming on to how and what. So first and foremost is where to place the incision. So for incision placement, we should go from distally, following these planes to towards the medial malleolus. So where to stop? So like if the infection or the NSTI is in the first web space, then we can start from the first web space and go down till we reach the healthy granulation tissue or healthy tissue in the foot. Till that we can go. And if it is if it is the infection is there in other parts, other web spaces also, we can collapse these there also. So what we can follow is red, amber, green method during debridement. So what is red? Red is the center of the ulcer or gangrenous zone. That should be completely debrided. There should be, it should not be left at the time. Amber zone is the surrounding zone which is relatively avascular. That also need debridements, but there would be some normal healthy tissue and which need not to be excised. So this process we can follow during the debridement. So though IWDSG doesn't recommend hydrosurgery as such, but in our center, especially in non-experienced hands like ours, we have a hydrosurgery equipment which we use sometimes to debride, because we are an upcoming institute. We have a limited number of manpower in surgical department also. So sometimes we have to get our hands dirty and do the debridement ourselves also. So this is the video. I think it is. I am not able to play it here. So with this, the job is much easier, and the good thing with it is it does the debridement layer-wise, and relative time is saved in especially in non-experienced hands. Oh, it's playing. So this is you can see here our resident is debriding the previous ulcer which I have shown. So it is relatively easy. Now moving on to the foot amputation. So what are the various foot amputations? So foot amputations can be either classified into a distal or minor amputations, or to a proximal or major amputations. So anything above tibia, that will constitute a major amputation. That is below knee amputation or above knee amputation and hip disarticulation. So what are the minor amputations? So minor amputations in forefoot toe articulation, it can vary from toe articulation in forefoot to Siams or Pirgoff amputation in the hind foot, which I'll show in the next slide in the cartoon. So here you can see this is if a partial the toe is debrided, that is the partial toe amputation. Amputation or disarticulation at the level of metatarsophalangeal joint is toe disarticulation or toe amputation. Then another one is a ray amputation, which is this amputation at the level of tarsophalangeal joint, but along together some part of metatarsal is also removed. Mostly the head of the metatarsal is sacrificed. The next level is transmetatarsal amputation, which is along the metatarsal, midway between metatarsals. Then comes the Lisfranc's amputation, that is between metatarsals and tarsal bones. So this is Lisfranc's amputation. Then next level is Chopart amputation, which is nothing but amputation at the level of calcaneocuboid and talonavicular joint. Then Siams is at the level of lower end of the distal tibia. That is, this is Siams, and it is Siams modified is known as Pirgoff amputation, which leaves some part of talus behind. So this is one of our patient who had a second wet gangrene, and you can see post second toe ray amputation was done here. After healing, it is almost, and it healed in almost 3 to 4 weeks. This photograph is after 3 to 4 weeks. So I'll show you another photograph which was done from outside in the coming slides and how it fared. So this is the transmetatarsal amputation at the level of metatarsals in another patient. This is another patient in which we have done a transmetatarsal amputation. And this is a Lisfranc amputation. You can see here that there is severe necrotizing soft tissue infection was there. And subsequently patient needed a Lisfranc amputation for the same. What should not be done during the amputation? So here you can see that the bone is left off. So this should, at the end of the amputation, it should not be, that bone should not be left bare. Here also you can see the bone, part of bone is left alone. So better thing would have been here, array amputation would have been a better thing. So this kinds of amputation should not be done. Like I was telling you before, the patient which we got, here someone has done a second toe disarticulation only, and bone is clearly exposed, subsequently have led to infection. And we proceeded with we completed the ray amputation, and subsequently the wound is now ready for a grafting. Now, especially in dorsal ulcers, the covering of wound by split skin grafting also helps. So this is a patient, you can see initially he has a severe an STI. Subsequently on day 3rd or 4th, he developed a line of demarcation, and subsequently he needed partial amputation of the third toe, ray amputation of the second toe, and subsequently once the wound was better, there was a nice healthy granulation tissue, split skin grafting was done. So now moving on to surgical offloading. So I'll just give you an overview. So this is one of the most common procedure, and which DFG also advocates for hammer toes, which is flexitinotomy. It is quite simple. You just have to, at the base crease of the toe, you place it can be done either with a needle or a small scalpel blade of number 11 to 12. So just place the needle there and just tout the toes, the desired toe, and just decise the tendon along the line, and you can prevent the further development of ulcer. This is one of another patient which he was having a recurrent callus and ulcer formation at the base of 4th metatarsal, where we have done a metatarsal osteotomy. You can see here metatarsal osteotomy, and patient was asked to bear weight immediately after that. And this is after 2 weeks of this metatarsal osteotomy. This is the wound. Another procedure which can be done for rigid hallux, where movement of the thumb is not, movement of the great toe is not good, and which can lead to ulcer formation, is callus arthroplasty, which is nothing but the removal of the base of the proximal phalanx of the first toe. Then similarly, if first metatarsal head is removed, if ulcer is there, sitting there, then which is known as first metatarsal joint resection, can also be done for ulcer, for surgical offloading of ulcer at the first metatarsal joint base. And something like that, pan metatarsal head resection can also be done if whole of the forefoot area is susceptible for ulcer development. Another thing which can be done, especially in patients who have undergone transmetatarsal amputation or Lisfranc amputation, because subsequently they develop the equinovarus deformity also, is tendoachilles lengthening, which can prevent the further development of stump ulcer in them also, and or gastrocnemius recession can also be done. This can also be done in patients who have chronic Charcot, like Rahul previously has also discussed. So this is one of the patients where gastrocnemius recession was done. You can see ulcer is sitting here in the forefoot area, which has sealed subsequently. Another thing, for excessive pronation, what can be done is the release of this tight peroneus longus and transfer of this peroneus longus to peroneus brevis, which will release the pressure and make the foot more stable in that way. Similarly, for excessive supination, what can be tried is splitting of tibialis anterior tender and transfer it to from cuneiform bone to, sorry, it is written cuneiform head, it is cuboid bone. So, which can correct the deformity. So, role of surgery in chronic Charcot, Rahul has already touched. So, exostectomy, especially some exostosis is there, but it will need, because in this foot there was some equinovarus deformity also. So, this patient needed tendo-Achilles lengthening also. Similarly, here you can see in unstable Charcot, especially at the ankle, which are more difficult to handle. Here, what they have done is they have removed this necrotic talus and fused this calcaneo tibia joint and applied an external fixator subsequently. And you can see afterwards there is a nice anatomical fusion is achieved. Similarly, mid-foot Charcot correction, very few centers in India are doing right now, but results are not that good, but some of the centers say that in good hands it can be performed, especially in those patients where conventional offloading fails to achieve the desired results. So, to conclude, time is tissue and early recognition does save the limbs, and multidisciplinary team approach is essential for management of diabetic foot, and when to operate is equally important as to what to operate. Elective surgery can be done in some settings to surgically offload the patient, deformity correction, as well as reconstruction, especially in chronic Charcot. Amputation should be functional and it should not be radical, it should be minimal, and the ultimate aim should be to have a functional foot along with prosthesis itself. So, just I'd like to acknowledge my co-surgeon here who has given me some of the pictures, and thank you.
Thank you, Dr. Priyandar, for your excellent presentation, which is very often less discussed in our area. So, thank you. One of the important minor surgical intervention would be the removal of the callus, which we can do in our day-to-day practice because with removal of the callus may reduce around 30% of the pressure. So with this we end our session, and now we have a few minutes in which we can take some few questions. I would ask our faculties to please come onto the dais. Professor Jeba Singh, Dr. Rahul, Dr. Madhvi, and Dr. Priyandar Singh. Please come into the dais. So if you have any question, please ask our experts.
There is a Chinese proverb, if I hear, I forget, if I see, I remember, if I do, I understand. But there is no such workshop should have some tools which is lacking in this.
Yes, sir. I definitely appreciate your concern. We have tried to bring some patients with real, particularly to remove the callus, but unfortunately we didn't arrange that. That is our concern. I must appreciate.
At least some shoes, which is important.
Yes, sir, definitely. If you have any questions, sir, please.
Another question. In quantity, diabetes patient is more in village, because village population is more than town, urban area. So village patient have come with thick sole, because they are barefoot. So how we test by monofilament with this 10 gram monofilament? How? Because it is not possible.
Okay, your concern is as the rural people walks barefoot, so there may be thickening of the skin by which we can appreciate by 10 gram monofilament test.
And how many area? That is 5 area. Suppose this is a sole. This 1, this 2, this 3, 4, and this 5. So how many area we test? Then we see say something going on wrong.
Okay, sir, Professor Jeva Singh, sir, if you answer the question, please.
So, thank you for the question. So, what we actually tell is in CMC value is we usually say 10 points, not the 5 points or 4 points what we given in the textbook or even in the IWGDF guidelines. And so we start with 2 gram monofilament, go to 4 and go to 10. And 10 is actually a very good sensitive marker to say that some patient has a foot reduced sensation, or in other words loss of protective sensation. So even 6 points on a 10 gram monofilament is a very good sufficient, because if you look at the Hansen's disease, they use a higher gram of monofilament, much higher, and that is for anesthetic skin. So here also anesthetic skin, but it is not to the greater extent of the Hansen's disease. So you can very well use 10 gram monofilament, and 6 times, so if they are able to perceive less than 6, that means definitely peripheral neuropathy, and you should advise them to check the simple maneuver is check the foot daily, check the footwear daily, and whenever they come to examine the foot. That is because the lacking point is in both the clinician as well as the patient aspect is the inspection of the foot. And patient come back with a larger foot ulcer because they walk paradoxically on their foot ulcer. They will having a probably 1 centimeter, they walk on there and get foot ulcer, which is probably 5 centimeter when they come back to us.
Thank you.
Thank you, sir. Any question?
Dr. Ghosh, one who saw that there is so many tunicate hair, but there is so many tunicate hair and there parts. So how wide? Because today we use electronic blood pressure instrument. But it was possible by the mercury, but not this how.
So please specify your question.
How we measure this?
Specific devices are available which can, with specific sizes cuffs, which can measure segmental pressures at particular levels.
But we actually use electronics BP. But is it possible for this?
With that.
Okay.
So we need specific size cuff.
Is your question is with the electronic machine you can use it? Actually, if you really look at that, I am not sure whether you used the electronic machine on your own. When there is gushing of blood pressure, you can actually palpate it. When there is gush of blood, and you can use your own BP machine, which is actually an automated. You can, if you have a crude way, it's a very extremely crude way, and palpate and see when there is gush, and you can probably say that at 100, when the blood pressure drops from 200 to 150, you have some blood, but it's extremely crude. We do use in our peripheral center where there is nothing, but with the modern blood pressure sphygmomanometer with your stethoscope, that's also is a good one to really measure. But if you're having a sophisticated method, you could use a Doppler. See, India is a country with vast and wide financial status, and I do work in 3 centers: tertiary center, secondary center, and primary healthcare center. So I use a different method in different ones. So I think that's a way to go about it.
Thank you.
Regarding your first question pertaining to the thickness of the skin and perception of the monofilament, saying irrespective of the thickness of the skin, few things need to be kept in mind that monofilament should not be used in the areas of callosities, number 1. And number 2, whatever might be the thin thickness be, if the monofilament is not being perceived, it substantiates a neuropathy of a degree that increases your risk of foot ulceration by almost 1.5 to 2 times.
Thank you.
Okay, any question? Okay, if there is no question, then we conclude our session. Thanks all my speakers.
One question.
Okay.
So medical management of Charcot's food in acute condition and in chronic condition, with special reference to role of bisphosphonate therapy.
Now there have been 2 RCTs which have shown that use of bisphosphonates does not lead to a time to remission of Charcot's from acute to a chronic phase. Considering that the benefits are doubtful and the harms can be there, the current IWGDF do not recommend use either bisphosphonate or even denosumab.
Okay. One of my question to Professor Jebasing sir, regarding the use of SGLT2 inhibitors and the diabetic foot amputation. So, will you use or you will recommend to use SGLT2 inhibitor and foot amputation patient?
In one study on canagliflozin, it was shown and it has actually retracted back actually. If you look at the study, they actually initially, the rebuttal was that it does not cause. And we do so in our clinical practice, several patients on SGLT2 inhibitors, and our follow-up is quite good. The reason behind is we cater patients of around 100 kilometers and around 20-30% comes from outside Vellore. So those who actually come for follow-up, there are several patients we don't see clinically, but in the studies it's shown to be, but it was not, eventually there was a rebuttal and then it was retracted back. So it is not actually, even in the literature also, it is not a cause for an increased amputation if somebody is on a SGLT2 inhibitor, especially it was shown in the canagliflozin.
Okay, thank you sir. Just one question, Madhvi ma'am. How frequently we do image in a patient with sarco neuroarthropathy? Is there any specific timeline? This frequent you have to do MRI or something else? Do you have any point on that? What do you recommend?
It's not based on the imaging timeline. It's purely based on the clinical timeline. I mean, if it's worse, we don't have any particular just based on the images. Like you have to image at 1 week or 2 weeks. So that's based on the clinical call. I mean, if the symptoms are persistent or symptoms are worsening, then we can repeat as frequent as within 1 or 2 days, or we can delay if the symptoms are improving. It's purely based on the symptoms,
okay,
but not on the image.
Okay, now just one more point. What do you see actually, the bone marrow fat or bone marrow edema or bone marrow intensity in MRI?
Yeah, so we do assess the basic sequences. The conventional sequences still holds good. So on the conventional sequences, the basic sequences are fluid sensitive sequence and T1 sequence. So on fluid sensitive sequence, the normal marrow is low in signal because the fat is suppressed. And any fluid anywhere, whether it is bone, soft tissue, it will appear as a brighter. On T1 is the most important sequence to assess whether there is any osteomyelitis or not. On T1, it's a fat suppressed, and the fat, because the fat content is on T1 is usually brighter, any subcutaneous fat. And most marrow will have the fatty marrow, and because of that, on T1 the bone will appear as a bright signal, or it will look like a hyper or white. So if there is an edema within it or any osteomyelitis, so that particular abnormal bone will look hypo or darker in signal. So the normal fat signal is lost.
Okay.
So we should have the fluid sensitive and T1 are the most important. In addition to the other advanced sequences like diffusion or even the perfusion ones, but usually we avoid the contrast and even diffusion weighted because it just increases the time of the MRI.
So by which we compare this intensity? Right? Do you have any value, Hounsfield value in the bone marrow fat? Or just we compare with what? Subcutaneous fat?
Yeah, so there is no value for it, no numerical value for it. It is just the expected normal signal for the bones in any adult patient. Like beyond 25 years, most signal is because of the fat content. So on T1, the subcutaneous is also the fat content. So the subcutaneous, any fat on T1 is brighter. So if you compare with the subcut, or even if you compare to the adjacent bones, so comparing with adjacent bones is more helpful than comparing with the subcutaneous plane, particularly in a diabetic foot, because there's already a soft tissue edema and cellulitis that appears as low signal on T1. So it's ideal to compare with the nearby bone. Suppose if there is a midfoot charcut, it's essential to compare with hindfoot rather than the forefoot, because sometimes forefoot signals could even be an artifactual, and if you don't have a dedicated MR coil, foot coil, if you're doing with the head coil, then it may artifactually look low signal. So that is something to remember.
Thank you, ma'am. Thank you. Okay.
They talk about the osteomyelitis follow-up. They say, you can give antibiotic for 6 to 12 weeks of your choice of a local and do an X-ray after healing after 6 months. But we generally don't follow at all, because I don't see any where is that guideline came from, because there is no study which talks about follow-up X-ray at 6 months and 12 months. Not even a single study which is really clearly evident to show that that's helpful. But the guidelines keep on writing the same for quite some time. So, but it's all about clinician, as Dr. Madhavi rightly said, it's a clinician discretion. But guidelines, if someone asks what is the guideline, it's actually 6 months and 1 year you have to repeat an X-ray, which is, I don't know in what context, but right now we are looking at that part and repeating X-rays for those patients. See, is it really valid?
So in CMC payload, you are just giving more importance on the X-ray or MRI. That depends on the, obviously on the context.
X-ray.
X-ray, okay.
What we do is, every patient who has a foot ulcer for more than 6 weeks, more than 2 centimeter and more than 3 millimeter depth, we do X-ray for everyone. It's a mandatory to do an X-ray, because one of the commonest cause for non-healing is an undiagnosed osteomyelitis. Very common, and we see plenty of osteomyelitis untreated more than 6 weeks. If it is clearly, let's say there is sausage too, there is some serous discharge, the X-ray is not very clearly evident, we immediately call Dr. Madhavi and say, can you do an ultrasound? And ultrasound is done in 24 hours, and we know whether there is a breach in the cortex or some collection, and if it is done, and it will give a cumulative, because we do a lot of medical management of osteomyelitis quite a lot. Almost 80% of patients are on medical management up to 6 to 12 weeks, and we see we don't have data on hand, but we are looking at the data. But most of the patients get cured, and if the ultrasound is not evident, then we go for an MRI. And the guidelines does not talk about ultrasound at all, zero. We got X-ray, X-ray positive, treat it, X-ray negative, go for an MRI. But MRI is expensive,
it's costly,
one, and we take
not
some
available.
time.
Exactly.
Not available. So that's why we use ultrasound to see, and we did a study and found that ultrasound do pick reasonable amount of as a pit stop in between, rather than just jumping onto MRI. So and that is how we use it. And subsequently, if the osteomyelitis is not healed, despite of giving antibiotic, we go for surgical offloading. This is an algorithm we use.
Thank you, sir. Just last question to Priyandar, sir. So just tell me about any brief idea about the renal diabetic foot. In patient with ESRD patient which come with diabetes, foot ulcer.
Usually we see most of the patients who with multiple or triopathy, all the complications are there. So CKD, foot ulcer in a CKD patients has many things.
Usually infrapopliteal involvement is much more there.
The
Calcification,
vascular
calcification.
will be there. Then this thing, certain imaging would be a problem. Like you won't be able to do contrast guided studies, especially if the patient is having CKD stage 3 or stage 4. Not in end stage, but stage 3 or stage 4, you won't be able to do. And those are the challenges. And other challenge is the cost, because if the patient is having end-stage renal disease, we may be preparing the patient for dialysis, as well as he would be having concomitant retinopathy or CSME, for which he would be receiving treatment, and subsequently he would be having an ulcer, which would add to the burden of the cost, as well as he would not be able to work, and he would not be able to earn also. So that are some of the factors which we should keep in mind.
Thank you. Thank you. With this, I conclude this session. Thanks all my speakers. Thank you.
Thank you for this wonderful session. Thank you to all the esteemed speakers. We are concluding this workshop on diabetic food, and those of you who are present here, so I'm just calling out the names. Those of you who are present here, please do come and collect the certificates. Our moderator sir is here, so I'm just briefly calling out the names. Please do respond if you are there. Aditya Daga, Anuj Ban, Anne Elias, Archana Rao, Arsad Musa CM, Bhanushri Kalava, Amulya Reddy, Divya S, Jagriti Nandwani, Arvind Kumar, Naga Bhagyashree Mangam, Nikhil Sanjeev, Piyush Agarwal, Prithijit Kole, Remya, Shelly Shapra, Sri Hari, Thusara Nayani, Aditya Ramesh Daga, Anjali R. Nair, Anvit Sherwin Pinto, Archana MH, Arsad, Bandana, Chandramouli.
Thank you.
Harini Jayaraman, Sanjay Kumar, Good Simran Singh, Kunal Gupta, Maitri Doshi, Milind Gaikwad, Nithu Joy, Pratyush, Raghavendra Pandit, Shinam Gupta, Siddharth Panigrahi, Sonalika Shahu, please do inform others to take it from the registration desk. Thank you. Okay, can you please? Okay, so I'll take it. Everybody, please attend hall, the Subhash Mukherjee Hall. So for the rest of the sessions, which will be starting very soon after the end of the workshops there. Thank you.